service availability and readiness assessment in Pakistan. The reports are ready. They will be shared with you. So he had to say a few words. I had to say a few words. And then this is the thing which he came actually. He didn't come for that. But Ellen and WR, we requested them to be there. Over to you, Bushra, and I think you can make up the time which we have lost. Over to you. And we welcome WR.
National workshop. I would like to especially thank WR for taking time for get the order for today's workshop session. Start the event, I would request our respective speakers to the card. According to WHO, every day approximately 830 women die from preventable causes related to pregnancy and childbirth. However, most maternal deaths can be prevented through effective interventions and care during pregnancy and delivery. Reducing maternal mortality and morbidity remains at the center of national and international needs. At the 1994 International Conference on Population and Development in Cairo and 1995 World Conference on Women, the rights of women to have safe pregnancy was the Sustainable Development Goal (SDG) states that the maternal mortality ratio should be reduced less than 70 per 100,000 live births by 2020. Henceforth, the objective of today's workshops are to present the important findings from the in-depth analysis of PMS 2019 working of professionals, health policymakers, researchers, and practicing clinicians in order to start a discussion on the next steps to strengthen and improve the maternal health services in Pakistan. We will also identify the need for further analysis of PMMS 2019 data and identify the need to have further focused qualitative and operational research. Lastly, in the afternoon session, we will gather to have panel discussions to draw policy-oriented conclusions and recommendations from the in-depth analysis of 2019 PMMS. In addressing the women's reproductive health. I would like to invite Dr. Aisha Shiraz, Senior Fellow at National Institute of Population Science, to give us a speech.
Honorable Chief Guest, respected VC, development partners, distinguished guests, and ladies and gentlemen, Assalamu alaikum and a very good morning. Research organization established in 1986 and currently it is working under the umbrella of Ministry of National Health Services Regulations and Coordinations. We have been mandated to act as a technical arm of government to provide evidence-based data and information for utilization by public and private sector and other agencies for policy formation, strategic planning, and making reference in the spheres of demography, population, and development. Pakistan Demographic and Health Survey was conducted into an attempt to conduct for the first time to get an accurate maternal mortality ratio at the national level. And then the maternal mortality ratio was 276 deaths per 100,000 live births. Then later in 2018 and 19, we were finally able to conduct the first exclusive nationwide survey. The highlights will be given later. It has come that the maternal mortality rate has come down to 186 deaths per 100 to the previous figure. Ladies and gentlemen, maternal mortality has remained one of the large indicators for developing countries, like including Pakistan. Maternal mortality ratio indicates the risk of death during pregnancy, childbirth, and post-birth periods, and it is considered the most sensitive indicator of women's health and status in country, and it is essentially reflects the quality and accessibility of health services available to the women. Millennium Declaration of United Nations adopted this MMR as an indicator of maternal health in the year 2000. And later in SDGs, it was conducted in 2015, and it was Pakistan is also signatory to SDGs, and they have said that they will reduce the maternal mortality to 70 per 100,000 live births by 2030. Though there has been a drop of around 40% in the maternal mortality worldwide since 2000, and we still have 10 years to go. Every day, 100 of women die from preventable diseases and pregnancy and childbirth. And the disturbing aspect is that situation is around 90% of the maternal deaths occur in low-income countries. Maternal mortality is a very serious issue. And on behalf of National Institute of Population Studies and Health Services Academy, I welcome you all to this national disseminate event of in-depth analysis of Pakistan maternal mortality survey. And we are particularly grateful to the chief guest for sparing his time. Thank you.
Thank you, Dr. Aisha. I would now like to request Dr. Shehbaz.
I think I already welcomed. I'll just make a point that, and I was mentioning it to WR as well, that HSA is lucky to have very big names, not just names, but actions. They have proven with their actions in the last decade, I guess, that they are the champions of MNCA. So we are lucky to have Professor Farid Middat. He is the pioneer in maternal mortality estimation, verbal autopsy, and his doctorate was in maternal mortality. And he gained a lot of skill as well as name in conducting all of this. So whenever you tell anyone that Farid Middat is here, they understand that the maternal agenda will be on the table in HSA. We also have, Professor Brigadier Ambreen Anwar, and she is one of the few gynae oncologists, UK trained, Pakistan trained, served in army, and now she's a professor as well here in MNCH. We are lucky to have Nabila Zaka. She had a huge experience in UNICEF, but associated with HSA as well. Sadia is heading, Professor Sadia is heading the MNCH, family medicine department, but she's a gynecologist plus MRCOG plus MRCGP. So the blend of this general practice and gynae is needed in Pakistan. That is why our family medicine program is much advanced than any other program in Pakistan, and we are having a huge, interest from Balochistan, from Sindh, from KP as well. So I just wanted to tell you that this is, and Samina had been here since 2007-8, or maybe even before that. Dr. Samina Naeem was here, reproductive physiology, MNCH. She headed a lot of consultations, researches and I think among all of them, she was the first one to start the MNCH department in HSA. She is currently back in HSA, and so this makes you realize how strong and robust MNCH department HSA has developed in the last 3 or 4 months. And we are moving forward with a lot of other endeavors. This is just an in-depth analysis of what we have done, but Farid Middat Saab will tell you that we have applied for a lot of other research grants in MNCH. We have done a lot of other guideline development, population. So we will be working on health, population, and nutrition. All three are cross-cutting. When you talk about nutrition, when you talk about population services, when you talk about health, it ultimately favors the women and the children of this country. Any project of nutrition will favor a child and a woman because they are the ultimate vulnerable. Any intervention on population planning or population services will help the women. And this is how we are taking it, not directly, but indirectly through population, nutrition, and like the World Bank program of HNP. I am focusing more on HNP integration, health, nutrition, population. The World Bank program of health is similar approach in Pakistan previously. The population was separate, health was separate, nutrition was separate. It was a fragmented approach. Now these, my champions of MNCH, they are leading in nutrition, in population planning, and health. Dr. Sabina, I think she's not here, but she may be there online. She will tell you that HSA has partnered with the population wing of the ministry. Officially, the team went there, and Sabina was very much impressed by the quality of. Partnered with the population wing of the Ministry of Health for doing a lot of work together in MNCH, nutrition, population, and health. That's all. And then I think if anything is needed, we are here.
I would now like to request Dr. Sunita Manipala to share.
To everybody, my brother, Honorable Vice Chancellor of Health Service Academy, this great academic institution, Professor Sasad Ali Khan, and all the renowned, respected, esteemed, distinguished academic faculty of Health Service Academy, Alan from WHO and my colleagues from WHO, all the other distinguished participants, ladies and gentlemen. Today, I consider this as an extremely important exercise which we are engaged in. I see maternal death as a public health issue and as a social issue and as a right issue. It's beyond the individuals, it's a family issue as well. So therefore, we need to really look at, when we look at the intervention, now to provide quality comprehensive services for antenatal care to deliveries to postnatal care, we need to review what we are doing, where are we. So reviewing all the maternal deaths is extremely important. Now to review the maternal deaths, you need to notify the maternal deaths. Now we are going still by survey data. Now we are trying to come out with the WHO Health Service Academy and the Institute of Population Study, a policy paper for the policymakers to consider to make sound decisions, but based on surveys. Actually, we should have the real-time data on maternal mortality. So you can see where are we. And if you look at CRVS, he whispered to me, and last few days we were talking about CRVS, and there's a mission came from HQ Geneva and regional office on this. And if you look at the total number of births registered in Pakistan, which is something around 27%, deaths must be much lower, maybe 18%. So you lose 80% of deaths, and 18% you are reported. If you look at, mostly you don't know the cause of death. You know, if you look at bed health tickets, most of you all are medical doctors. We see a very funny causes of deaths or diagnosis written. The common is PUO, that is pyrexia of unknown origin. Nobody know what it is. And then you have LAMA and RAMA. You know what it is? RAMA is remove against medical advice, and LAMA is left against medical advice. So these three consider 80% of the diagnosis. And so how you are going to give the deaths? Cause of death. Cause of death is for everybody cardiorespiratory failure. So this 18% which we have records, again, we don't have data. So therefore, I think we need to have legislation not on notification of maternal mortality, which is a prerequisite. And then once it is notified, we need to have institutional maternal mortality review. And at the institutional level, we need to look at this, how it happens. And then, of course, you have to take corrective action. And this institutional review, you need to spread to the district level, provincial level, national level. I'm sure these are the kind of practical actions we can take. We can have wonderful documents. We can have so much of, good and comprehensive strategic plans. But yet, if it is not implemented, it has no use. So therefore, I request, when it comes to the policy recommendations, I'm sure you will look at the recommendations at the institutional level, recommendations at the community level, recommendations at the provincial level and the national level. If you don't look at the institutional level, how much ever policies you have at the national level, it won't work. How much ever policies you have at the institutional level, if you don't have national legislation and policy drive, you can't achieve it. So these are extremely important areas for us to look at. Now, there are a lot of tools developed, and the framework developed by WHO, there are two critical areas we are focusing. One is care giving, and other is care experience. So two areas. Are we respect the mothers who come to the institution? Are we look at their dignity? Do we respect to them? Do we deliver a comprehensive care? We need to look at that side. At the same time, we need to look at through the indicators, are we delivering quality comprehensive services? To my eyes, not in Pakistan, but in other countries, mothers are dying due to non-suturing of episiotomy scar. You give the episiotomy, but you don't suture it, and they bleed and die. This is what happens at the institutional level. So there are still, if you go by number of deaths, whatever the data available, maybe it is bleeding, maybe it is still infections, and many other countries, the cause of death for maternal deaths are medical conditions, not the maternal conditions, not the bleeding, not the infections. It is mainly a heart disease and so on. So still we are at very primary level. So we need to really look at the holistically all these areas. WHO has discussed about 3 delay models sometimes back. I think Alan and Kutsia will enlighten on this. Delay at the community level, delay to come to the institution, delay at the institutional level, and delays before that. So we really need to look at all the maternal deaths when you review, looking at all this. There's another tool where we again start to monitor the cesarean sections, Caesar rates. Cesarean section is a life-saving measures, but we have seen that there are so many Caesars are being done. Some of the tertiary care institution, it goes up to 60% of the deliveries. So you need to look at, you do over interventions, and finally you have complications and deaths. So therefore, my request to you all, as the esteemed medical profession is in this audience, we need to look at holistically. We have to be practical. We should not be in ivory towers and look at things theoretically. but we need to really look at practically how we are going to address this issue. So my personal experience is, if we start with the maternal mortality review at the institutional level, you put the things on right. You should not be aiming at inquiries, but it should be VOGs and other people who are involved should come out and tell this is what has happened. Look at it as a system issue rather than an individual issue. If you look at it as an individual issue, people won't be able to come and tell the mistakes they have done. You have to learn from mistakes. That's how you can move forward. So these are the few comments I thought I should share with you. And countries have moved forward from many digits to single digits. And there are some countries who have zero maternal deaths. Zero maternal deaths. So it's not a high cost intervention, it's a low cost intervention. And it's an intervention where you do some work for the humanity as well. So we need to change the mindset of people. And if you think that reduction of maternal mortality needs so much of funding and cost, I don't think that's right. You need to change the mindset only, and you can overcome many things. So thank you so much for inviting me. And this is a subject very much close to my heart. Losing a mother, you can think about what will happen to the husband and to the children. The whole family will be in a trouble, and it will be a social issue as well. So therefore, we have to look at beyond the numbers. We always look at 186 per 100,000 live births. To me, it doesn't mean anything. But if a mother is lost, you talk to the child, what a misery for that family and to the child. So we have to look at beyond numbers as well. So I'll stop here, and I hope that this recommendation will be taken up very seriously, and accordingly the interventions will be done. And by another 5 years time, when we meet together in another conference, and this has come down to single digit. Thank you so much.
We're proud to have him as the lead of our RMN and Fish Party, consultant for the We're fortunate that Dr. Workshop and raising the
exact figure at the rate, it will tell you how much actual MMR is universe can vary. So take this 2006, MMR was 276, but 95% confidence level, which means if you do another survey, you will not find it. Hopefully it will be between 234. Actual MMR in the country can vary between. In 2019, MMR estimated national level 6, ranging from 1. So which means that 234 the lower limit of 2007. 34 is the upper limit of 19, should not have happened. It should be or above. Matching, so that risk is statistically significant. Translation, we have reduced MMR, and the reduction by the way is about 33%. But this is very marginal. It's not enough. Should have gone further down. I was actually expecting more like 140, 150. Then if you go into the provinces, unfortunately, it actually proves my point. So if you compare the same way, the 4 provinces for which we have data from the 2 surveys, you see all of the confidence intervals actually grew.
Dr. Fareed, there are some online, Haris, there are some online people who say they can't hear Dr. Fareed's talk. Just check it again, and then, because they are sending me messages that they can't, and they came here to listen to Dr. Fareed actually.
It's much better now, actually.
Okay, I hope this mic is now working, so can you let me know? I'll try to repeat a few things again. Okay, so this is basically the comparison between provinces, and you see that actually the MMR between provinces is overlapping, which simply means that the sample sizes are not large enough to actually, say that yeah, we have reduced the provincial MMRs also. Okay. It has reduced in each province from 227 to 157 in Punjab, from 275 to 224 in Sindh, and the largest decrease is from 765 to 298 in Balochistan. Okay, but that's not like for sure that it's actually the case, because the overlap between confidence intervals gives us like doubts that maybe actual reduction is not there. So that's where I will leave you. You can think about it. You can like make your own judgment. And next slide. Okay. This is the comparison of the cause of maternal death, and the cause of maternal death actually is the classification which we are showing here right now is not exactly the same as it was in 2007, but we did use the same like the International Classification of Diseases version 10, ICD-10, WHO, for basically classifying the categories of causes of death. So they are very, very comparable. What is happening here, you see that the obstetric hemorrhage, which is postpartum hemorrhage mostly, it has actually increased in 2019 proportionately. Okay? So overall, the number of maternal deaths is coming down. Out of those who die, in larger number, 41% as against 32 or 33%, are dying due to postpartum hemorrhage. Similarly, for hypertensive disease, and similarly for abortion-related death, the actually larger number, proportion of women dying due to 3 causes. 3 causes came down: the indirect obstetric causes, the other obstetric causes, and the infection. Okay, very simple explanation. What is happening here is that probably the access to health services has increased. which means that the women can get to a hospital. It's still in some areas, of course, women cannot, it's not good enough for women who are having postpartum hemorrhage. If the woman is having PPH, she's probably have 2 hours, So in 2 hours, maybe she cannot breathe. So the system is saving the women who are reaching there in time, but not others, So it's still, I mean, it's a progress, but it's still not good enough for the mothers, unfortunately. But that's indication. So here, this is just a very, very brief comparison, and you hopefully will have presentations from others who will explain it further. Just to let you know that how we actually did the in-depth analysis, this is a simple cross-correlation. There are 2 variables on this slide: the presence of lady health worker in the village and a pregnancy outcome. Okay, so a bad pregnancy outcome is stillbirth or neonatal death. So if you cross them together, you see, these are actual numbers. You can actually see the percentages also. If you cross them together, you see if there is a relationship or not. So if a village has a lady health worker, which is yes above, then it should have more live births, fewer stillbirths, and still fewer neonatal deaths. Because the lady health worker is supposed to help the women have antenatal care, postnatal care, etc. And if you want to know whether this relationship is statistically significant or not, you calculate odds ratio. Okay, so you actually calculate chi-square test here. Okay, and that will tell you whether this relation is. You can also calculate what is called the odds ratio. I'm using this example for outcome of the last pregnancy and compared with the odds ratio for maternal mortality. I'm sorry, you should say somewhere maternal mortality. So what is happening here? The women who had stillbirth, abortion, or miscarriage in their last pregnancy, previous pregnancy, they are 2.57 times, almost 2.6 times more likely to die of maternal causes than the women who have live birth. Live birth is a reference here. Okay, so this is an odds ratio which actually tells you the odds of maternal death among the women who have stillbirth, abortion, or miscarriage, okay, which are higher than the women who had a live birth. Okay? This is an odds ratio between just 2 variables. But we know that, basically what is happening here, the last bad pregnancy or poor pregnancy outcome indicates the woman had some problems already, So that's why she maybe died next time. She shouldn't have become pregnant next time, but she did, and she died, unfortunately. But there are other factors also. They're like, distance to hospital is a factor, age is a factor, parity is a factor, maybe anemia is a factor, lots of factors, right? So it's not just one risk factor. There are many, many risk factors. Therefore, we do what we call the adjusted odds ratio. Okay? So we calculate the same odds ratio, but after removing the effect of age, parity, urban rural residence, and socioeconomic status, okay, it's still significant. This gives you some trust in your results, in your data, and actually the likelihood has increased slightly. So basically, what you're seeing here that even after you remove the effect of parity and age, and urban rural residence and socioeconomic status, this is still a risk factor. Okay. So if a woman has had a poor pregnancy outcome, it should actually ring a bell, So the doctor should be alerted that, okay, this woman may die next time. Let's do something about it, okay? So that's what we have found here. So it's a lot of data, and hopefully you will enjoy. And thank you so much.
Thank you very much, Dr. Mithil. I would now like to invite Dr. Aisha Shiraz, Senior Fellow at NIPS, to deliver socio-demographic determinants of maternal mortality in-depth analysis of PMMS 2019.
Today I have to deliberate upon the
socio-demographic determinants of maternal mortality. These can be the high risk of maternal mortality. It is by myself, Professor Mubashir Hamid, Ms. Bushra, and Dr. Fareed Bilal. Next, please. From 2000 to 2017, the global maternal mortality ratio declined by 38% from 342 deaths to 211 deaths per 100,000 live births. And according to UN interagency estimates, this translates into an average annual rate of reduction of 2.9%. While substantive, this is less than half the 6.4% annual rate needed to achieve the Sustainable Development Goals of 70 maternal deaths per 100,000 live births. Maternal mortality is the health indicator which shows the greatest differential between developing and developed countries. The majority of maternal deaths occur around the time of delivery, and much efforts have been gone identifying and providing effective and appropriate delivery care to prevent these deaths. The data source include the National Sample Survey of Pakistan Maternal and Mortality Survey, which included more than 100,000 households. Already Dr. Fareed has deliberated upon these, that these were 1,177 female deaths in the reproductive ages to identify 170 maternal deaths. I would like to thank and add that there was NMNCH Department of Doctors for this identifying the cause of death. We have collaborated with this section. It was headed by Dr. Sadka Jafri and Ms. Dr. Azra, and they have a panel of doctors. They identified the causes of death, and then they gave the underlying cause of death and immediate cause of death. As that Dr. Fareed said, that mostly the causes of death are reason cardiac arrest and unknown causes. So for identifying the cause of death, we have this department for doctors, gynecologists, and they have identified these deaths. In the subsample, we had 14,000 women of reproductive ages. These were interviewed and detail of their most recent pregnancy ending in last period were obtained. It was a nested case control study. All maternal deaths included cases, and the controls were randomly selected from women who had a pregnancy ending in last 3 years. The cases and controls were not matched, and study has 90% power to detect odd ratio of 1.75 or higher at 95 confidence interval. The data analysis method included comparison of maternal deaths with controls and women surviving a pregnancy in last 3 years by a known risk factor of maternal mortality, that is age, parity, history of prior pregnancy loss, education, socioeconomic status, etc. And there was chi-square test, and the logistic regression included to compute adjusted ratios, the risk factors of maternal mortality as independent variable and the case controls as dependent variable. Now I would like to discuss the results. Age at birth is very important for maternal mortality. It is an important factor, and it is found that the women who were 2.83, they were more at risk of dying a maternal death as compared to the reference category of 20 to 34 years. And more than 35-year women had 1.9 times more likely to die of maternal cause as compared to 20 to 34 years. Parity of a woman is also very important component, and this shows women having more than or equal to 5 live births. They have 1.4 times more likely to die of maternal causes. They were high risk pregnancies. If they have more children, they are at higher risk. The outcome of pregnancy was also observed in the logistic regression. As compared to live birth, we have seen the stillbirth, abortion, and miscarriages. And the woman having more than going to the doctor for stillbirth, abortion, or miscarriage, 2.57 are more likely to die of these causes as compared to live birth. Women mostly go to the skilled person for the healthcare provider in case of emergency. So this regression shows that women who have gone to the doctors, LHB and obstetric gynae doctors, they have 2.31 times more likely to die of maternal mortality. Diseases like high blood pressure and diabetes are causing complication in pregnancy and childbirth. And it predicts that 2.67 high blood pressure women had maternal mortality as compared to no hypertension history. More women are suffering from diabetes in last pregnancy. They died of maternal death. In comparison, 3.9 are more likely to die of maternal death. So the women who were died, who were having the diabetes, they died more. The distance to headquarter and maternal mortality was also observed, and it is found that the women, if the reference category was the urban areas where they have more access to health services. The woman had more than 35 kilometers, equal or more than 35 kilometers. They had more chances of dying or risk of dying as they have to reach to their place. And when they asked the woman, when in the villages, they said that after 7 o'clock, they do not have any transport available to go to any health facilities. And this is very important that if they do not have any transport, they cannot reach the facility to have this care from the doctor. And later we adjusted these figures. The effect of outcome of last pregnancy on maternal mortality was observed as reference to the live birth. It was found again that 2.74 more chances of or risk of death for these women. Our use of family planning is also very important, as this family planning, if a woman is using family planning, they have more distance births, spacing in the births, and they have less number of children. So they are in better position. So it is found that it is 5.4 times more likely to die the women who are not using any family planning. The effect of women education is a game changer, and you know that the education of women is more important as compared to, we have seen in some of the surveys that the education of men is less important as compared to education of women. If the woman is educated, she can have more effect on her health and her during childbirth health. So when we have observed the reference category, which is less than 10 years of schooling, it was found that the women who had higher education, they are 2 times less likely to die in the maternal cause of death. Again, we have seen after adjusting the other components for age, parity, residence, urban, rural, and socio-economic status variables, we have found that high blood pressure women died. It was 2.67 more deaths were found as compared to with women having no history of high blood pressure. Similar is the case of diabetes. It is even more higher than the hypertension. If the woman have diabetes, she has 3.53 more times she is likely to die in the maternal death. The effect of distance of district headquarters is in the village areas. It was also found that more than 35 kilometer distance is having more effect on the deaths of the women. Now I will conclude that after adjusting for socio-economic and demographic variables, the following risk factors emerge as important determinants of maternal mortality. That is poor outcome of last pregnancy, never using any family planning method from last pregnancy, no schooling or less than 10th grade of schooling, and history of high blood pressure and diabetes in pregnancy.
Thank you, Dr. Aisha. All this data is very interesting, but can be very heavy to digest. I guess we would like to have a tea break now. Dr. Pahikala will kindly join us for the tea break, but we'll have to leave after that. Thank you.
Once down, क्या हो गया अब आई नहीं की बात
लैपटॉप यहाँ नहीं आ सकता कि we can change it. आपकी pointer है
ना
दसो
पॉइंटर ना ही है जान गया
और इसी से स्लाइड चेंज होती है
Hello. Hello.
They're on tea break?
the session for National Workshop on Maternal Mortality, I would now like to invite Dr. Samina Naeem to present his profile of women who had an induced abortion during the last 3 years. Dr. Samina Khalid is a maternal and child health consultant. She's working as associate professor at HSA.
Thank you very much, Bushra. And I'm really grateful to all the participants over here. I hope we are going to have fruitful discussion today, and I'm really thankful to Dr. Fareed for giving us insight into the maternal mortality survey findings and all the participants who have joined from their respective posts. I'm going to talk about profile of the women having an induced abortion. It's very important that we look at the women. Actually, this study was not actually in the maternal mortality survey. It wasn't looking at the rates and ratios of the abortion, but since there was a question in the survey that women who had a termination of pregnancy in the past 3 years, we look at the profile. I had with me Dr. Faiza Haq, Ms. Alan Hong, Dr. Kutsi Osman, Ms. Azra Aziz, and Dr. Fareed as the lead. So we are going to talk a little about the definitions and then general facts and figures, adjusted odds ratio to do the statistical analysis of abortion cases. And then we are going to adjust them and look at the statistics. We will talk about active methods used before last pregnancy, and we'll conclude with a few remarks and then the key message. We are going to define the term, what is an induced abortion? When a woman does not use any method of contraception or uses it ineffectively, unwanted pregnancy occurs, leading to either induced abortion or an unwanted birth. The induced abortion can either end up in an unsafe abortion, which is the procedure for terminating pregnancy carried out either by persons who are not skilled enough or in an environment which is not sterilized, and it does not conform to the minimal medical standards. And a miscarriage, we did not look at the miscarriages because it is a spontaneous loss of pregnancy before the 20th week of pregnancy. General facts and figures. Abortion is a common public health intervention, and it is safe when carried out in sterilized environment. 6 out of 10 unintended pregnancies end up in induced abortion. Around 45% of the abortions are unsafe. This is the reason we want to look at the factors, and 97% of these abortions occur in undeveloped countries. So unsafe abortion is a leading cause of maternal mortality, and lack of access to safe and timely and affordable abortion services is an issue. We are going to talk about the findings from Pakistan Maternal Mortality Survey 2019. We took 170 women who gave us the history that they had a termination of pregnancy in the past 3 years. So we cannot actually look at the rates and ratios because it was underreported. There was a direct question. It wasn't intended to find out the real abortions occurring. And when I'm talking about 170, this is induced abortion. These are not miscarriages. So a nested case control study was designed to compare the women who reported an induced abortion with those who had a live birth. Odds ratio were adjusted for age, parity, socioeconomic status, and urban and rural residents to explore the factors leading to induced abortion. Women reporting an abortion were taken. 100% of the sample of the women who gave us a history of induced abortion, they were taken as cases, and 20% of those who reported a live birth, that is 1,729, which is one case for 10 control. Power was 90%, and confidence interval was 97%. Let's look at the facts. We looked at the fact of age on the risk of induced abortion, but we actually found out certain factors. So we also looked at the unadjusted ratios and we adjusted for age, parity, household socioeconomic status, and urban-rural residents. When we looked at the fact of age, we found out that the women who were more than 35 years or were 35 years of age, they actually went for induced abortion. But just to look at the other factors, they were 1.3 times more likely to go for induced abortion in comparison to the 25 and 25 to 35 years, 34 years age. So we adjusted it for different factors, which I have just mentioned, and we found out that the adjustment did not make any difference, and they were slightly more prone to go for induced abortion. We looked at the effect of parity. Effect of parity on the risk of induced abortion. When we looked at it, we found out that the women who had 0 to 1 live birth, they were 2.9 times more likely to go for an induced abortion. This is a very strange fact that 0 to 1 live birth, that in the past they just had one maybe live birth and they were prone to go for induced abortion. We actually presumed that maybe this was an unplanned pregnancy. They were not thinking, they were like newly married couples and they were still not planning to have a baby. So when we looked at, we took 2 to 4 live births as control, and when we looked at the more or equal to 5 live births, it was 1.6 times higher. It means that definitely it was higher for the women who had more than 5 kids, 1.6 times, but the women who had 0 to 1 live birth, it was 2.9%. It was highly significant statistically. And when we adjusted it, we thought that maybe there are certain other factors like the socioeconomic status, maybe the urban or rural residents, because we found quite differences in these residences. So we tried to adjust it for that, and we found out that after adjusting a few factors, we found out that when we adjusted for these factors, the rates were not significant. So when we adjusted it, and we found out that it has even increased 3.5 times, they are more likely to go for induced abortion for women who are 0 to 1 live births. It means that it was highly significant statistically. Then we looked at the fact of pregnancy history on the risk of induced abortion. And again, we looked at the unadjusted and adjusted ratios. We found out that the ones who had none in the past and the one who had 1 or more live birth, they were 1.6 times more likely to go for induced abortion. And it did not make any difference even after we adjusted it, or it remained the same, 1.6 times. We looked at the number of gravidas. So when we looked at it, and we took 1 to 5 pregnancies as the reference value and looked at nulliparous women and the ones with 6+ pregnancy, we found out that after adjustment, they were 2.7 times more likely to go for. It means that the women who had 6+ pregnancy, well, that makes sense. They did not want to have a baby. So the women with 6+ pregnancies, they were going for induced abortion when we adjusted for other factors, and it was highly significant. When we looked at the fact of household socioeconomic status on the risk of induced abortion, we found out that this factor was quite significant. They were 4.7 times in the middle income group and 6.4 times more likely to go for induced abortion. So we did the adjustment and we tried to find out whether the effect dilutes, and it still remained quite high, 4.4 times with the middle income. It means that the socioeconomic status was quite significant, and it was affecting that the women who were economically sound, they were going for induced abortions. Effective residence. When we looked at the effective residence, we found out that the women were 1.7 times more likely to go for induced abortion in urban areas, but when we adjusted for other ratios, it diluted to 1.2 times. So it has effect, but it actually has, there are certain other factors which we are talking about. So again, when we looked at the women's education, we found out that the women who are educated or whose household are educated, they are more likely to go for an induced abortion. 0 to 9 classes or 10 plus classes, the women who are educated more than 10 grades, they are 1.7 times likely to go for induced abortion. But when we adjusted for other factors like socioeconomic status and rural urban residents, we found out that the facts diluted and it was not that significant. Again, when we looked at the effect of the household education, that the members of the other members of the household are educated, their average education is higher, we found out that they were 2 times more likely to go for induced abortion. But again, when we adjusted for other factors, which came out to be quite prominent, the effect was diluted to 1.2 times from 2 times. They were at double risk. Next is effect of use of contraceptives. Well, we were really interested that the women who had 6+ pregnancies, they were going, the women who had high socioeconomic status, who had urban residents. So why they were not like going for contraceptives if they were not planning a pregnancy? We looked at the effects of the contraceptive and we found out that effect of use of contraceptive. The ones who were not using any contraceptive, we looked at the modern and traditional contraceptives and we found out that the women who were using modern contraceptives, they were 1.8 times more likely to go for induced abortion, and women with traditional, they were 2.8 times. That means around 3 times more likely to go for induced abortion. When we adjusted for the factors, socioeconomic and the urban residents, we found out that the fact was not diluted. They were still 1.8 and 2.6 times more likely to go for induced abortion. So this is a prominent factor which we found out. We were really interested that the women who were using modern contraceptive methods, it makes sense that the ones who are using traditional methods, maybe there was a failure of method, but the ones who were using modern contraceptive methods, why they were going for induced abortion. So we looked at the details and we tried to actually categorize, and we found out the same fact was that women who were using modern contraceptive methods, they were 1.8 times likely to go for induced abortion. But when we looked at it and we segregated the data, we found out that the women who were using long-acting reversible contraceptives, they were 2.8 times more likely, even more than the traditional method. This is very strange that the women who were using modern contraceptive methods, the LARC, which is supposed to be quite protective, there was a failure somehow from our end as providers, or maybe from the receivers end. So LARC, which we are thinking and we are promoting, that the long-acting reversible contraceptives give us more safety and they are promoted in our community, more acceptability is there. So what is the reason for failure? We have to look at it. We also look at the data that maybe the women who prefer, who have more sons, maybe they go for induced abortion, and the ones who have doctors. So we segregated the data and there was no difference in that. So then we concluded that from the findings, we found out that the women more than 35 years age are more likely, 1.3 times more likely to go for induced abortion. Women with 0 to 1 live birth are even more likely to undergo induced abortion, 2.9 times, while women with more than 5 live issues are also 1.6 times more likely to go for induced abortion. Women with past history of pregnancy loss are 1.6 times. Maybe, then we presume maybe in the past they also had a termination of pregnancy, or maybe because we have not actually digged into the data beyond that, women with 6+ pregnancies are more likely to go for induced abortion 1.6 times. And after adjustment, it increased to 2.7 times. There is 4 to 6 times increased risk of household socioeconomic status. This is a prominent factor, but we cannot help it that if they're economically sound, even after adjustment, the rates remain 4 to 6-fold increase. So there is 1.7 times increased risk of induced abortion due to urban residents. So maybe there is more availability of services, or maybe they have more knowledge of the sites to go there. But the fact diluted when we actually adjusted it for the socioeconomic status. Women's education and household education also came out to be a prominent factor, but again, it diluted when we adjusted for the factor. So, what we can like take a key message? How can we conclude? We can talk about the residents. We cannot work on the economic status. So, what we can do is we found out that the modern contraceptive methods, they have failed at some point. Maybe the counseling component was not there, maybe the continuation was not there. So we need to promote the use of modern contraceptive methods for family planning to prevent abortion. So take-home message is induced abortion is a major cause of morbidity and mortality. The significant factor which came out of the analysis is failure of uptake of contraceptives, like specifically long-acting reversible contraceptives, and unmet need for family planning should be addressed and continuation should be encouraged. Thank you very much. Thank you for being patient.
Thank you, Samina. I would now like to invite Brigadier Dr. Amreen Anwar. Brigadier Dr. Amreen Anwar will present a cesarean section rates and profile of women having cesarean section. She holds both FCPS and FRCOG and is a medical educationist as well. She's currently based at HSA and is involved with different projects of maternal health and has a special focus of maternal mortality.
Assalamu alaikum. I'm extremely grateful to the organizers and Dr. Fareed Midhat to give us an insight into such an abundant data at the national level, which has not been shared before. And my job here is to talk about the cesarean section rates and profile, the demographic profile, not the medical, of the women who underwent cesarean section. Next slide, please. The slide one. Now going back to the history of cesarean section, it has been documented to exist since ancient times. It is basically an operative method to deliver the baby as compared to the normal vaginal birth. Numerous references appear in the ancient Egyptian, Hindu, and other European folklore. However, the first recorded successful cesarean section was done by a lady physician in the early 19th century by Dr. James Bailey, who was serving as a physician to the British Army in South Africa. As I defined that it's the delivery of baby through a surgical incision in the uterus. And the common indication which come forth as medical indications are fetal distress, malpresentation, breech, you might have commonly heard. The baby labor does not progress at the rate which it is intended. And now very common with the modern obstetrics, a previous history of cesarean section. Another thing that has come up with obstetrics coming as a modern specialty is the medical disorders like diabetes and hypertension, where you might have to rescue the baby early through a cesarean section so that the bad effects or the side effects or the complications of diabetes and hypertension, the baby is saved off. Globally, cesarean section rates have risen from 7% in 91 to 20% in 2020. And that is more so to help save the perinatal mortality and morbidity. Well, now we're coming to the hardcore data. PMMS 2019, it included a detailed questionnaire, as you have heard since morning. And these women of reproductive age ever married. A subsample of the household were visited in the survey. And it elicited detailed information about the pregnancies that ended during the last 3 years. It included information about the mode of delivery, whether it was a normal vaginal delivery or whether it was a cesarean section. Among about 15,000 women who were interviewed, half of them had a pregnancy ending during the 3 years prior to the interview. So were all included in the data institute. The analysis method to the interest of tradition would be that the cross-tabulation between the normal vaginal births and those through the cesarean section were included to calculate the rates. Then statistical significance was calculated to determine if the rates were significantly different across the categories, and a chi-square test was used for that. Logistic and regression analysis to estimate the likelihood outcome of cesarean for selected independent variables after controlling for the socio-economic and demographic variables was used, which you would now follow in the as we go around the graphs based on the data. Now, the overall cesarean section, as you could see very clearly, as compared to the rural, in urban population, it is exactly double. If we go by women's age at birth, it's not surprising that 25 to 24 years of age, when woman is at the peak of reproductive years, obviously the reproduction rate is high, and so is the cesarean rate. If we look at the parity, we see that the peak is in those giving birth after 1 or 2 births. And that is the reason most likely is that these women were having a previous one cesarean section, which about 70% of them end up in a repeat cesarean section. More than 5, obviously, they had given birth, so they were less likely to undergo a cesarean section. Then we come to the women's class as compared to the, as regards their education. If they ever went to school, could you see that the difference is so high, 3 times? If they ever go to school, they cannot take grades. So they end up in cesarean section. That is the connotation that comes out of this now. Now, same if we go by classes, how much the more educated they are, the more is the risk of having a cesarean section. If we look at the wealth quantile, that was calculated by looking at the assets the women had, and it shows a very steady increase along the quantile. You see the highest the quantile, highest the rate. Previous pregnancy loss actually did not show any difference, because most likely even one miscarriage or a couple of sporadic miscarriages or losses were included in the history, and it was not the classic bad obstetrical history, which we use a term in obstetrics. So it didn't show any difference. Now the pace of delivery. ये देख ले भाई, government hospital में it's 21%, and in private hospital it was 34%. We really don't know why, but maybe the woman had more choice to exercise in private hospital. Maybe we are not sure. Well, if you look at the symptoms during pregnancy and delivery, we could see that the peak, as I mentioned, that the indication for cesarean section is malpresentation, breech. 50% of the women admitted to having a malpresentation. Diabetes is the second leading cause, and so is hypertension. So any medical disorder, obviously, as in Dr. Vinod's presentation, he looked at those women who reached Dr. Aisha's presentation, that women who reached hospital had a higher chances of having mortality, and so is having a higher chance of cesarean section, because these are the women who are actually suffering from some complications. Now, those women who had prior diabetes or hypertension, as said before, 46%, and hypertension still goes 24%. If they have problems during, that is medical disorders, the mean number of problems 5 times, and a cesarean section will, as compared to 5.8 normal delivery, these women will have 6.4 times risk of cesarean section, which is statistically significant. Among women with high blood pressure and diabetes, as we said before, the adjusted ratio for age parity schooling was adjusted, and still the high degree pregnancy 1.43 high risk, and diabetes 2.7 high risk for cesarean, which is totally true. It goes with the data is true to the sense that it goes with the medical literature. Now, to conclude that women living in urban areas, women who have a higher education, who are having higher socioeconomic status, delivering in private hospitals, having medical problems, have high rates of cesarean section. That is what the data concludes. Why it happens, if we look and reflect through the pages of history, we see a concurrence to this data. In the early 20th century and the late 19th century, there was increased urbanization and growth of hospitals around the US and Europe. And cesarean section operation began to be performed routine. Most rural births were undertaken by the midwives till the late 19th and 20th century, till the special hospitals came in. And that was a time where urban population, large number of working women class appeared, who obviously did not have the family at hand to support them. And in the cities, meantime, the obstetrics was born as a hospital-based specialty that squeezed out the midwives. Midwives are, by the way, the nurses who are trained to carry out a vaginal birth. And only doctors can undertake a cesarean section. So it seems from the data that it's a matter of availability, accessibility, as well as acceptability among the urban and educated women that led to higher cesarean section rates. But we'll have more fruitful discussion once we come to the panel discussion. I'm grateful to you all for hearing me.
Thank you very much, Dr. Reem. I would now like to call upon Dr. Qudsiya Usman from WHO. She's going to present us perinatal mortality in Pakistan rates and associated risk factors. Dr. Qudsiya is a public health specialist with around 20 years of professional experience. She has worked with ministry. Do you want to come? Let me just introduce you. She has worked with ministry, international NGOs, and currently affiliated with WHO Pakistan. Her technical areas of interest are reproductive, maternal, newborn, child, and adolescent health. Thank you. Assalamualaikum. So the topic of my talk will be perinatal mortality findings from the Pakistan Maternal Mortality Survey. Just to give you a brief outline, we'll be just going through the importance of the birthday. We'll be defining perinatal mortality rate, and then going to skinning through the key results, and finally some messages. So just to highlight that the intrapartum and birthday is basically the time which puts
hundreds and thousands of mothers and newborns at risk. And globally, majority of deaths among mothers and newborns are happening around this time. Perinatal mortality rate, you can look at the equation here. It's basically defined as the sum of stillbirths and early neonatal deaths divided by the total live births, and it's represented as perinatal mortality rate per 1,000 live births, total live births. I'll not go into the other details about how the survey was taken place, because many speakers before me have already talked about that. So these are the results of women who were interviewed and who shared their, who had a pregnancy that was ending in the last 3 years, almost around 6,700 plus women. So if we look at the perinatal mortality rate by provinces or area of residence, overall in Pakistan, it was included as 70. But we can see we have a very high figure in for Sindh, for Balochistan, followed by Balochistan, and the lowest figure in Delhi, which is significantly lower. By wealth quintile, again, a very predictable pattern. It was found to be the highest in the lowest quintile and the lowest in the highest. And this was again significantly lower. By type of residence, urban and rural, very little difference in terms of the rate itself. And it was also by mother's parity, again, there were differences, and it was found to be highest in women having 6+ pregnancies. And this was found to be significantly higher rate as compared to the other death rates. By mother's age group, again, it was found to be the lowest in women aged 25 to 34 years and highest among the extremes of ages, less than 25 and 35 plus. And this was the 25 to 34 years category was having significantly lower perinatal mortality rate. By mother's prior pregnancies, excluding the last pregnancy, again, we found differences among newly gravid, 1 to 5 pregnancies and 6+ pregnancies. 6+ was having a very high rate as compared to the other two categories, but these differences were not significant. Perinatal mortality rate by mother's education. So we found in other characteristics as well that no schooling was playing a major role, and it here again it seems to have a high risk for perinatal maternal mortality, but having 10th grade or higher education was found to have the lowest, and this difference was significantly lower than the other categories. Similarly, education level of the head of household, again 10th grade or higher was having a lower risk, and this was also significantly lower. Perinatal mortality rate by skilled birth attendants, there was a difference which revealed that those who had access to skilled birth attendants, they were found to have a higher perinatal mortality rate, and this was not significant. We'll look at the same while we'll be going through the logistic regression figures. Perinatal mortality rate by facility delivery. Again, if a woman is going to for facility delivery, it needs to have a high risk. But again, this was not found to be statistically. By type of facility, again, private facilities were found to have more risk for perinatal mortality, but this difference was not statistically significant. Very interesting finding. We also looked at the availability of LHWs and their regular visits to the households. And it was found that if there were LHWs available and if they were also paying regular visits, those mothers were at lower risk of having a perinatal mortality, ending into perinatal mortality. But unfortunately, this difference was for both of these categories, we were not statistically significant. Now we'll go through some logistic regression results to share with you the adjusted odds ratio while adjusting for effects of women's age at birth, parity, women's education, and residence. So if we look at the wealth quintile categories, you can see that the trend that we saw in the bivariate analysis is also seen here. That those in the lowest and the second lowest categories are having a much higher risk of ending into perinatal mortality, and it's also significant. In terms of parity, the adjusted odds ratio are not that hugely different and are also not statistically significant. Mother's age, again, we found that there was a high risk for 20. It was lower among 25 to 34 years of age and higher for 25, less than 25 and more than 35. But in case of adjusted odds ratio, we find that it's mainly the more than 35 years age category, which is having a much higher risk, 1.3 times more at risk of ending into perinatal mortality. Mother's education, again, we were looking at the protective effect of 10th grade or higher, but the adjusted odds ratio shows that no schooling is actually putting them at 1.63 times higher risk of ending into perinatal mortality. This is a very significant statistic. Antenatal care, again, they are availing antenatal care. They seem to have, there is a little bit of protective effect, but it's not statistically significant. Stillbirth attendance, if women are availing stillbirth attendance, they are almost 1.5 times at higher risk, which is very significant as well. And this could be due to the reason that mostly complicated cases are seeking help and they are ending up with stillbirth attendants or facilities for their delivery services, and therefore they are counted as those who are seeking stillbirth attendance, but again ending up into the because of the complications ending up into perinatal mortality. So the key messages that we can draw from these statistics: wealth and geographic inequities are still there in the perinatal mortality. And risk of perinatal mortality increases with the increasing age of mothers. We just saw the adjusted odds ratio. Again, no schooling of mother and that of head of household is again a significant risk. LHW's availability and their regular visits are having almost no bearing on perinatal mortality, and this might be due to quality of their services, some issues around quality of their services. Use of ideal antenatal care again is found to have no protective effect on perinatal mortality, and again we can assume that it has something to do with the quality of care issues. Although we have seen our data showing much progress and much progression in terms of ANC and stillbirth attendance. Use of stillbirth attendance again and high perinatal mortality, association of these two could be due to quality of care issues or due to the fact that mostly all complicated cases are, they do accumulate, they end up with care providers. Thank you so much, and we look forward to further discussions with the panel.
Thank you, ma'am. As we are running ahead of our time, we have decided to do another presentation before we do the question and answer session and proceed to the prayer and a lunch break. So I would like to invite Dr. Rabia Zafar to present us patterns of health services utilization during pregnancy, childbirth, and postpartum. Ms. Rabia Zafar is a research fellow at NIPS. So she has 30 years of experience in health demographic surveys and research.
Thank you, Vishnu. Bismillahirrahmanirrahim. Assalamu alaikum. Now I will talk about the patterns of health services utilization during pregnancy, delivery, and postpartum. Next. Data sources and data analysis. Pakistan Maternal Mortality Survey interviewed ever married women of reproductive ages about health services utilization during pregnancy, childbirth, and postpartum period in the last 3 years. Rates of maternal health services utilizations were computed by women's biological and socio-demographic characteristics. Logistic regression analysis was carried out to estimate the likelihood of maternal health services utilization after adjusting for the socio-demographic variables. Now I will present the bivariate analysis results. For this analysis, we have used the indicator ideal antenatal care, which includes women having 4 and more visits to a skilled health provider during pregnancy, at least 1 visit in the first trimester, blood and urine tests carried out and BP measured, iron tablets prescribed and nutritional counseling given, at least 1 TT injection received. Overall rate of ideal ANC is 21%. Next. Utilization of ideal ANC by mother's education. The slide shows that use of ideal ANC is increased with women's level of education, women with 10th grade or higher education are twice as likely to receive ideal ANC than women with 1 to 9 grade education. Still, their proportion is small, only 43%. Now the ANC by age at birth, we can see that ideal ANC utilization was more common among middle age group women, 25 to 34 years compared to other age groups. Next. Now by parity, bivariate results show that mothers having 1 to 2 births receive more ideal ANC compared to mothers having 6 or more births. Next. Now the place of birth. As expected, urban women are almost twice as likely to receive ideal ANC than their counterparts. ANC by region, it is highest in AJK, 36%, and lowest in Balochistan, which is 4%. Now the ANC by household wealth, the graph depicts the large differentials in the utilization of ideal ANC by household wealth. It increases with the increase in wealth. Women in the highest wealth quintiles are more likely to be received ideal ANC, which is 47%, than women in the lowest wealth quintiles, which is only 3%. Percent of delivery outcomes using skilled birth attendance by women's education. Skilled birth attendants include obstetrician, specialist, doctor, nurse, midwife, lady health visitor, or community midwife. 85% of delivery outcomes to women with 10th grade or higher education were assisted by a skilled birth attendant, while 58% were to women with no education. Skilled birth attendance by parity. The slide shows that utilization of SPA for last delivery outcomes decreases with the increase in number of births. Next. Now the SPA by region. It is highest 78% in Punjab, whereas in other regions the utilization of skilled birth attendance varied between 51% and 77%. SPA by wealth quintiles. The slide depicts that delivery outcomes to richest women are almost twice as likely to receive skilled birth attendance than poorest women. Now the utilization of postnatal care in health facility by education. Here I would like to mention that overall rate of PNC in a health facility is 57%. The slide shows that PNC has also increased with the increase in education level of women. Only 58% women with no education have received PNC as compared to 85% of educated women. Next. ANC by place of residence. The slide shows that 2/3 of urban women receive PNC compared to half of rural women. Next. And now the PNC by ideal ANC. The slide depicts that women who had ideal ANC for their last pregnancy are most likely, almost twice as likely to have postnatal checks than women who did not receive ideal ANC. Now the logistic regression models depicting the likelihood of health services utilization for each variable shown after adjusting for the effect of age parity, women's education, place of residence, and wealth status. Next. Now I will share the adjusted odd ratios and 95% confidence interval for ideal ANC care by education. The odd ratios of having ideal ANC are much higher for more educated women having 10th grade or higher education than those with no education. The effect of education is statistically significant on the use of ideal ANC. Next, please. Now the effect of age at birth, the slide depicts that only the women in the 35 years or older age group
are more likely to receive ideal ANC compared to women less than 25 years. Now, the effect of parity. Parity is a good predictor of the use of ideal ANC. Women having 3 to 5 births are 2.7 times more likely to receive ideal ANC than those having 1 to 2 births. Parity has a statistically significant effect on ideal ANC. Next. Now the wealth status, the odds show that women from the highest quintiles are 11.4 times more likely to have ideal ANC than the poorest women. This shows that with an increase in household wealth, women are more likely to have better opportunities to use ideal ANC. Next. Now I will share the odds ratios for skilled birth attendance by education. The odd ratios of having skilled birth attendance are significantly higher for delivery outcomes to more educated women than those with no education. Next. The effect of age at birth. The slide shows that delivery outcomes to the women in 35 years or older age groups are more likely to be assisted by a skilled provider compared to the delivery outcomes to the younger women. Next. Now the parity, the odds ratios show that women who had 3 to 5 births are 1.7 times more likely to get assisted from a skilled birth attendant for their delivery outcomes compared to those who had 1 to 2 births. Next. Effect of wealth status. As expected, the effect of the wealth quintiles on skilled birth attendance was found significant and increased with household wealth. Richest women are 4.3 times more likely to have skilled birth attendance than poorest women from lowest quintile. Next. Now the place of residence. Urban women are more likely to have skilled birth attendance than rural women. Next. Now the adjusted odd ratios for postnatal care in a health facility by education. The odd ratios of having PNC is lower for more educated women than those with no education. Next. The effect of age at birth. Women in the 35 years or older age groups are more likely to receive PNC compared to the younger women. Next. The effect of parity. Regression results show that women having 3 to 5 births are 1.3 times more likely to be received postnatal care than those having 1 to 2 births. Now the effect of place of residence. This slide shows that rural women are less likely to be used postnatal care than urban women. Next. Now the wealth status. The slide depicts that PNC also increased with household wealth. Richest women are 2 times more likely to have postnatal care than poorest women from lowest wealth quintile. Next. And now these are the key findings. Use of ideal ANC and skilled birth attendance is much higher for more educated women with 10th grade or higher education than those with no education. Women having 3 to 5 births are more likely to receive ideal ANC and skilled birth attendance than those having 1 to 2 births. Women from the highest quintiles are more likely to have ideal ANC, skilled birth attendance, and postnatal care in facility than women from the lowest quintiles. The effect of education, parity, and wealth status are highly significant on the use of ideal ANC and skilled birth attendance. Thank you.
Thank you very much, Ms. Rabia Zafar. We are going to proceed to question and answer sessions now. We've got attendance on Zoom as well. If the Zoom attendees can please write their questions in the chat, and our IT experts will help us to answer those questions. But first, we're going to move to the
our audience to put up their questions, and then we are going to give you the mic, and then our experts will decide who is better equipped to answer that question. You can raise your hand and we'll look for you. Nobody has any questions? Everything is very clear? I think somebody from here had a question earlier. No? Yeah, do you want to ask a question?
Yeah, sorry. Somehow it might be diluted to my memory, but as far as the first presentation was prepared, it tended to show that the role of the lady health worker did not have much of an effect to cater postpartum hemorrhage. So could someone address that? Despite that, the skilled lady health worker should be able to cater that, but yet the postpartum hemorrhage incidences, or rather the prevalence, were more. Thank you. I mean to say that despite the presence of the lady health workers, their presence did not cater much of the postpartum hemorrhagic effect, or aren't the lady workers trained enough to cater that postpartum hemorrhage? Because in one of the presentation, there was not much of a significant effect. That could be, I mean, a misconnection to my memory.
Before answering your question, let me first congratulate all the presenters and very, very refined presentations. It has been a real thorough joy to be here. On the question for lady health workers, I think it's also like when we see, what causes a disease or a condition, what can be done around it, and when a complication is identified, what needs to be done from there. Yeah? So if we look at the role of lady health worker, the role of lady health worker is to identify pregnant women in her community and to counsel them on seeking ANC care from a BHU, RHC, or the nearest facility, as well as to counsel her on her nutrition and care during pregnancy, and also to inform her about danger signs for which she should be seeking immediate hospital care. So these are the roles of lady health worker. And then she also supplies iron folic acid tablets, which are in her domain, which are also related to, if a woman is very anemic, you can understand that she will survive, have more chances of survival. Then comes like, okay, so this is her part. If this is being done well, if she has all the supplies for iron folic acid, and if she's doing her job well, then yes, anemia can be taken care of at the prevention level. But of course, if the woman is having a complication, and doctor, so many gynecologists here, so I'm also shy of what I'm saying, but PPH is usually two major issues, which are leading to PPH. One is the existing anemia, and the second is uterine atony. Yeah? As you have seen in the subsequent presentations, when they're always like parity above 6, so that's like, one predictor of mortality. So we can see that our anemia between the two nutrition surveys has not decreased. 50% of pregnant women are anemic. Yeah, more than 50, it's like 52. So that is stagnant. Then uterine atony, what are we doing? It's also oxytocin is available, irrational use. Then, if the woman develops bleeding, one is referral. What kind of referral support is there in the community? And secondly, what is being done at the hospital level. In the referral support, there is something which has been lately introduced. It's called non-pneumatic anti-shock garment. And I remember Dr. Farid used to talk about it years before. But now, Dr. Sab, it's in the procurement. It's available, at least in UNICEF procurement guidance. So that's there. And then, whether the facility has a blood bank transfusion facility or not. How is the care of the mother, during her labor and after that. So all those factors count. So it's not only the lady health worker effect, that we, yes.
Yes.
जी, Assalamualaikum, can you hear me? आप लोगों को आवाज आ रही? Can you please confirm if you can hear me?
Yes, we can hear you loud and clear. Thank you.
Okay, thank you. So first of all, congratulations to HSA, Dr. Farid, the NIPS team, Aisha, and everyone who is here. I think it was very interesting as much as I could attend. So for me, I mean, looking at, it's a very good, deeper analysis, but I think much more is desired. So the last question about lady health workers' role. Do we know lady health workers are inundated with other responsibilities? So a lot of our quality questions will come up in all the things that has been discussed today, when we see no statistical significance among women who go to the facility for better outcomes compared to those who have not been able to end there. Same goes for ANC and PNC. So I think the quality of care and what does it entail to, and how much it contributes to the ultimate outcome is going to be something that I would really request all of you to go deeper, to look into the issues. And same goes with the lady health workers. Are they trained? Do they know? Are they supported? Are they giving enough time? Are they updated? So, a lot of quality question. The other thing which struck me is, of course, relationship of a family among the family planning analysis, is that why women using LARC are ending up with induced abortion. And I would really would like all of you as researcher to dig deeper into that and what does it mean, because it is not, I mean, both from a theoretical and a practical perspective, it does not seem to fit the bill. But it's a very surprising finding, and I think it would be very helpful to know why it is happening and how this could be addressed. Thank you.
Sir, Farid Medat would like to answer that, please.
Thank you, Dr. Yasin. Can you hear me?
Ji, I can hear you. Ji, Farid Saab.
I think you are very right. Quality of care is an issue, and quality of care we have actually, we are looking at that also. I would urge you to join us in the panel discussion. Also, we have a presentation on policy implications, and in that we will also discuss the quality of care issue. In short, I think when you have skilled birth attendance and antenatal care utilization increased significantly and substantially, but there is no corresponding decrease in either perinatal mortality rate or in maternal mortality ratio, something is wrong somewhere, and somewhere is basically quality of care, I think. So this is where I think I hope that there are obstetricians also, Dr. Azra Hassan and others who can actually comment on that. So I really look forward to that discussion. We will further, go into the detail, further sort of next level of analysis we will do. So right now, like what we know is this, that the quality of care probably is the culprit, especially in the public sector hospitals. so far, we have investigated. And your second question also caught us by surprise. I think that abortion and, what is the relation between? So it's actually well known that, abortions in Pakistan are basically because of the method failure. And method failure usually associated with either it's a condom or a traditional method. So basically to that extent, it makes sense. What about lack? So it's, we have to look at further in depth also. But I think what is happening here is that the woman got an IUCD or an implant, and then she started having problems, and then she got it removed. And then she became pregnant. This could be only logical way, because otherwise, if you have an implant inserted or IUCD inserted, you cannot become pregnant. So obviously that's what is happening here. And I will actually suggest to maybe have a field study, separately on that. In my experience, I have seen that also, like working like as you know, at the grassroots level, that a large proportion of women who have implants inserted or even IUCDs, they come back in a month's time, so get this removed because of the side effects of the products. So thank you very much for highlighting these issues.
Thank you, ma'am. Do we have any more questions from our audience here? Okay. So we'll take a couple of questions from our audience here, and then we'll move back to the Zoom participants. I'll take one by one. I'll take first one. You want to use that one? Yeah, go ahead.
Okay, thank you very much. I think it was a very nice in-depth analysis of many factors related to the maternal mortality. My question is from Dr. Fareed. In your slides, you compared about the 2007 and 2019, but the PPH, like hemorrhagic maternal mortality hemorrhage was increased, much more increased. So could we find out what was the reason, as the other indicators like the antenatal care coverage is increased, as well as ideal care is increased, and also the lady health worker coverage is also increased. So what could be the reason? I think we have to look. And secondly, the same is with the hypertension also. Is it due to the increased diagnosis of hypertension with pregnancy with hypertension, or there is something else? Because there were quite marked increase as compared to the 2007 hypertension impact.
Okay. So,
Okay.
So
has a comment, please.
So that is very interesting, both the observation by one of the students regarding the stillbirth tenants and by you, madam, regarding postpartum hemorrhage. Now, there are 3 delays identified in the continuum of care. It's a continuum of care starting from the pregnancy. Rather, I would go back from that pre-pregnancy and girl-child care. Moving on to antenatal care, pre-pregnancy, that is, and intrapartum during the birth, and then the postpartum care. And all the reflectors which you could see. I have a very interesting anecdote to relate with this. Once I was back from UK, I was posted in CMH Kohat. I worked for Army. And Kohat is like one of the second biggest city of KPK. Now, what happened? I was the only gynecologist. It was extremely busy because most of the Pashtuns are in Army and they are distributed all over Pakistan. And the families are back home. And these women will really CMH mein muft ilaj hai, but the in-laws will unfortunately not spend even Raksha taxi ka paisa. And by the time they came to us, the game was over. Baharal, they came, and in 1 year, being a single gynecologist with my team of midwives, we did not have a single maternal mortality and that is documented in CMH Kohat. हाँ, ये खुशी की बात है, अभी आप सुने, अभी आप उसका दूसरा पार्ट सुनो. I get posted to CMH Quetta. Quetta is the largest city of Balochistan. Okay? I thought I am a brilliant gynecologist, not a single mortality because I'm UK trained and I'm so competent and whatever. And believe you me, every month we had a maternal. Because is somebody from Balochistan? And you would know जो बलोचिस्तान से हैं वो जानते हैं. इस पे किताब भी है अपने देश में अजनबी. तो वो वाकई आप अपने देश में अजनबी होते हैं जब आप बलोचिस्तान जाते हैं. 42% ऑफ पाकिस्तान का जो खिता है उसकी जो लैंड है वो बलोचिस्तान में. इट्स अ ह्यूज एरिया. लेकिन बंदे पॉपुलेशन सबसे कम है. तो आपको 5-5, 6-6 घंटे आप गाड़ी पर चलते हैं तो आपको बंदा बंदे की साथ तो दूर तक कोई प्लांट भी नजर नहीं आता. इट्स चिटियल मैदान. तो वहां पे वो औरत को दे पुट हर ऑन अ डोंकी वंस मतलब काम नहीं हो रहा, डिलीवर नहीं हो रही है, ब्लीड कर रही है, कुछ कर रही है. स्किल बर्थ अटेंडेंट तो वहां क्या ही करेगा. उसको दे पुट ऑन अ डोंकी एंड दे स्टार्ट. लिटरली इट इज 2020 आई एम टेलिंग यू. आधे रास्ते में फौत हो गई. They dafan her there and go back. सर ये अभी बात खत्म नहीं हुई है. जी सर मैं छोटी कर देती हूँ. नहीं टांगे में डिलीवर होने की बात ही है. बच्चे ने पूछा कि स्किल बर्थ अटेंडेंट और पीपीएच मैंने पूछ रही है कि क्यों बढ़ा. क्योंकि
I'm just asking about
स्टेटिस्टिकल यही बात कर रहे हैं कि पीपीएच कम नहीं, डायग्नोज ज्यादा अस्पताल चले. सर आप
the number of deaths has decreased. Okay? More maternal deaths are occurring proportionately due to postpartum hemorrhage, because the timing is required for reaching a hospital is actually much less than infections, etc. Okay? This is a common thing. If you increase access to health services, so those deaths who are actually, because of urgent, acute issues like the PPH, proportionately they will increase. But remember that the number of deaths has decreased overall. So which deaths are we preventing? We are preventing deaths from infection, maybe preeclampsia, eclampsia, and we are preventing deaths from maybe other obstetric causes or indirect obstetric causes. We cannot say we are not saving as efficiently. The number of PPH is also decreased, but proportionately it has increased in the cause.
But I would relate it with the infection, like there is a marked increase in deaths due to the sepsis. But that is also
sepsis has reduced. Death due to infection has reduced.
Reduced. That is markedly reduced.
Markedly, they can very reduce.
Yeah, okay. That's also related to the quality of care and the health-seeking behavior, as well as the
so there are few things which we can answer from the data. There's something which we cannot answer from the data. So we need, but you are right in that quality of care.
Explode more.
Yeah.
Thank you, Sir Fareed. Thank you, Ma'am Amreen. Anybody else with a question?
I would just like to add something to Amreen, because we people are handling these cases more rather than tackling with the data. Talking about the hemorrhage, main cause of mortality. Hemorrhage, basically, the social, cultural factors are also important in addition to lady health workers. Lady health workers will give you iron and calcium tablets. Even they don't know how to enhance the absorption of iron and how to give iron and all these things. But the pre-existing health of that woman, more than 70% women are anemic, pregnant women, more than 70% according to Pakistani data. More than 70% are anemic. The reason being, which we try to explore in our studies, in our smaller scale studies, are because they're social and cultural. The lady of the house has her last leftover meal. This is the culture of most of the places in Pakistan. The once whatever is left, the lady of the house gets that. Number one, inefficient diet, poor pregnancy planning. Unplanned pregnancies are more because of the lack of contraceptives as well.
And recently we have seen that implants, which was available few years back in 200 rupees, now we have to get it, arrange it in black with 2000 rupees. The availability of contraceptives, free supply of contraceptives is also a reason behind this. So pre-existing anemia, lack of contraception, all these factors and social cultural factors, all these factors do play a role in maternal mortality in addition to that poor lady health worker.
Thank you, ma'am.
Yes. I'm Dr. Nabia Tariq. I'm a consultant gynecologist working in Pindi, Islamabad, and I have a background from Azad Kashmir as well. I do visit there.
Thank you, ma'am. Yeah, kindly introduce yourself before. Yeah, okay. Do you wanna say? Sorry, ma'am. Please introduce yourself.
Assalamu alaikum. I'm Dr. Tahmina Yusuf and I'm consultant gynecologist at Federal General Hospital. First of all, I will like to thank all the presenters for making this in-depth analysis easy for us to understand. We are working on maternal mortality service for last few years, and we are putting a lot of efforts to find out the determinants and factors who are responsible for maternal mortality. My question is that we are heading toward the SDGs by the year 2030 कि हम 70 तक लेके आएंगे. Alhamdulillah, we have reduced maternal mortality from 276 to 186, but still there is a long way to go. So I just want to know, are there any strategies or policies that have been designed to get our targets by the year 2030?
Assalamu alaikum ji. I am Dr. Aisha Yasir. I am a student here. I've got two questions because since my both respectable gynecologists are sitting here, malnutrition और anemia जो हमने PPH का cause भी कहा है, तो our whole Sindh belt and our Balochistan belt जो है पूरी आपकी खजूर है. Why don't you recommend खजूर for आपकी iron deficiency के लिए, कि उसमें minerals भी हैं. So why do we just suggest हम iron ही हम prescribe करते जा रहे हैं? अब तो specialized nutritious formulas भी आ गए हैं. This is one question. And इसका other question मैं पूछ लूँ kindly. So Sindh में they have this गर्ल चाइल्ड मैरिज रिस्ट्रेंट एक्ट लगाया है उन्होंने, एंड वहाँ पे हेल्थ की कंडीशन भी नो कि जो फैसिलिटीज हैं स्पेशली जो हम रूरल सिंध की बात करेंगे इट्स नॉट गुड. तो हमने एंड वी हैव टू हमने कलेक्टिवली पूरे कंट्री का रिड्यूस करना है मैटरनल मोर्टेलिटी रेट, और इसी तरह बलूचिस्तान में तो हम क्या इन दो जगहों पे स्पेशली फोकस करके अपना अचीव नहीं कर सकते गोल? थैंक यू.
Thank you, ma'am. Who would want to take the answer for this one?
First, and maybe ask others to Dr. Ambreen and Nabila maybe to. I'll first take the Balochistan one because that bothers me a lot. Balochistan has changed. It's not like the same as it used to be. It is roads are almost always everywhere now, like it's connected, so. There are issues, of course, it's an underdeveloped province, but I'm not sure if the situation overall has been very different from the country itself. Okay? So my take on Balochistan and the rural Sindh is yes, the main reason I think for, of course, we saw also that the lack of education is one thing and access to health services another thing, of course, the quality also is not like, as Dr. Ambreen said that, you quote the quota, probably, quota is maybe 5 or 6 centers in the whole Balochistan, which have like higher level, tertiary level care quality, So that is still there. But having said that, I think we cannot like single out a province or a region and focus on that one. We have to have a national strategy to reduce maternal mortality. Okay, And that cannot happen. And coming to the question on the SDG, we are unashamedly, basically, we have been passing all the targets without achieving them. We moved from MDGs to SDGs. अभी फिर हम promise करके आ गए कि हम we will achieve that, we will not achieve that. I can guarantee that 70 is very far away. Okay, the reason being that there is not really very focused and I think concentrated effort to increase to improve the social indicators of this country, not just health. Okay, so unless there is my opinion as an individual and a Pakistani citizen, unless we have a different social contract between the whatever the government is, I don't know what is the government, and the people of Pakistan, that they will be focused on social issues. They will be focused on education and health and sanitation and water and security and accessibility and roads and transportation. This is not there anywhere. So, so you cannot you cannot reduce maternal mortality in isolation of everything else. Okay. So, but coming back to what Dr. Yasmin pointed out, and we also discussed that quality of care is an issue, and whether we agree to that or not, the data so far is indicating that even after increasing significantly the skill birth attendance and also antenatal care, maternal mortality has not actually significantly reduced. So a 1/3 decrease in 12 years is not much. Bangladesh has actually brought their maternal mortality ratio down almost to about 20%, like 80% down, in about more or less the same time period. And this is possible in Pakistan also, if only we would focus on the quality of care.
Thank you very much, sir. Any other questions from the audience? Sure, ma'am.
And the women have an average hemoglobin of 11. I moved from South Punjab, that is in Multan. In the main city, Multan, the hemoglobin used to be 8, average 8. And the woman bled normal delivery 500 ml and she would faint. So there are, it's as I said, it's not an isolation maternal mortality. There's so many social issues. In Balochistan, the distances are so long that by the time woman reaches there, she's already pregnant. She would lie in ITC for maybe a month, but you can't do it. So the 3 delays, which is first delay is decision making. As you saw in the data, the influencers in the home, they make a lot of difference. As I said, the Pathan, those Sasus will not allow her to go to see a medical. So the influencers' education matters a lot. Secondly, that is decision delay. Secondly, reaching delay, which I mentioned to you in Balochistan case. And third comes the provision of care, which is whether it's a stillbirth attendance at the facility the woman reaches, it's a nurse, or it is an obstetrician, and the condition of the woman. Now I come to the 4th delay, which I suffered in Karya, which is on the GT road. None of the facility is 5 minutes to 20 minutes drive from CMH Karya. But by the time the woman reached, I saw 11 maternal deaths in 11 months. Believe you me. And that was year 2019 to 2020. Because as we were discussing with Dr. Tamina, there's no proper reference chain. There was no information with those women, what has been done, halfway, what has been done, what they need to. And by the time they were being assessed, because they are so late, they reach you so late, what can you do? So in isolation, we cannot, unless, and returning to Tamina's question that SGDs we are moving, unless the gynecologist, and Navya is a senior gynecologist, taking advantage of that, unless we gynecologists come out as an army of gynecologists and make a collaboration with the population guys, with the Ministry of Health, with maybe Ministry of provision, say जो पता चला अभी मुझे recently कि बांग्लादेश में इसलिए contraception effective है कि Ministry of Population और Ministry of Health के वो under आती है. तो ये जो provision of contraceptives है, इस ट्रेन में कोई मसला नहीं. But यहाँ पर दोनों ministries अलग हैं, वो isolation में या जो भी उनका है वो काम नहीं करती इकट्ठे. और गायनेकोलॉजिस्ट के अलग वो ट्रेन पर हर बंदा आइसोलेशन में अगर काम कर रहा है तो ये तो स्टैटिस्टिक्स वैसे के वैसे ही रहे. हर बंदा इंडिविजुअली काम कर रहा है. आप भी कर रहे हैं, हम भी कर रहे हैं, बच्चे भी पब्लिक हेल्थ में बहुत आ रहे हैं, which is a very welcome news. But unless we join hands together, SGD नहीं हटे.
The good news is कि हमने बना के भेज दिया to merge the both the ministries so that they are on one board. Na? So let's hope that it goes through.
And today's event
चीज
again.
clear की नहीं है कि LHWs are not related to the postpartum hemorrhage directly. They are the counselors to send them timely. They are not the one who are going to treat it. So it's not direct influence. They cannot actually कर सकते हैं. तो this is one of the reasons. खाने का तो हम यही चाह रहे हैं, पहले हम सब healthy खाना शुरू कर दें तो बाकी will expect the women. Thank you very much. I think that we are going to like
So we are, so we are going to take the break now. We are going to.
You want to? अच्छा, question पूछते हैं जो online है.
So we've got
Hello.
Dr. Samia.
Hello.
Do you want to ask a question
Yes,
now?
Assalamualaikum. Yes, I'm Dr. Samia. I'm consultant microbiologist. I see it is honor to me to join your conference. It is the very key conference to the Dalmia of Pakistani culture because we are 169 position out of 172 countries. We are the very poor health condition for women. The birth condition for women and childbirth is very low. The world are alarming. Why we are grow lot of money, lot of NGO, lot of funds expend these, but the scenario is worse to worse. Water lock pulling, infection rate in the women is very high. Most of infections suffered by the fungal and bacterial infection. Neonatal meningitis is very common. How can control, how can work? Why not we jointly work to manage this situation? Because lot of fund available, but it is not used in proper way.
Thank you, Dr. Samia. I think this was more of a comment than a question. Thank you so much for that. Thank you so much for everybody coming for the morning session. We will start our afternoon session at 2 o'clock. It will have the policy implication presentation, and then we will have the panel discussion among our panelists. Dr. Nosheen Hamid will join us from the government so that we can put our recommendations to the government and have a practical outcome of the workshop today. And Alhamdulillah, this is a key thing that we have moved to today, that we are actually together here to give the recommendations to the government to have practical implications to reduce maternal mortality. And we are all playing our whatever little part we can. Thank you so much for coming for the morning session. This is the Jummah break now and the lunch break. And we will see you all here in the workshop hall at 2 o'clock. Thank you very much.
presentation on in-depth analysis of PMMS survey 2019. Then we went on to the socio-demographic determinants of maternal mortality. Then the third presentation was on the induced abortion, fourth on cesarean section, fifth on perinatal mortality in Pakistan. And then the sixth presentation was done on the patterns of health service utilization during pregnancy. Now the time has come for the seventh presentation, which is a policy implication of the results of PMMS 2019. As the chief guest is here, and we would like to resume with the presentation. The presentation will be presented by Ms. Ellen Thom. I would like to provide a brief introduction. She started her career in 1993 as a nurse in Malawi. Since then, she has worked with international agencies like Ministry of Health, Malawi, UNFPA, World Food Programme, Mothers to Mothers. And since 2011, she has been working with WHO. Now she is working in Pakistan since past 2 years now. I would welcome Ellen Thom for a presentation on policy implications of the result of PMMS 2019. Welcome, Ellen.
Thank you so much, Parliamentary Secretary for Health. This presentation, as said, is a summary of whatever has been discussed this morning, and putting that together and making sure that we come up with some policy suggestions on how we can improve the situation in Pakistan. So this presentation was put together by a team that has been put on the slide. I'll first of all look at the issue of trends of maternal health services, which was one of the issues that was discussed this morning. For the trends of maternal health services presented by Dr. Zafar, we see that the trends in antenatal coverage in Pakistan have been going high. They have been improving in terms of number of antenatal visits, the first visit happening in the first trimester, and also 4 or more visits during the antenatal period. You can see the red line down there. These are the 4+ visits. A steady increase from where we are coming from up to 2019. And the first visit in the first trimester, which is usually recommended, also the blue line, a steady increase. And antenatal care using a skilled provider also going up in the green line. But much as the antenatal trends are going up, we can also see the same trend in the deliveries by skilled birth attendants. You can see the green line here, a steady rise in skilled birth attendants, which is very commendable. But you can also see the red line of births happening in the homes going down, which is also a sign that most births are now happening using the skilled birth attendant as compared to home deliveries. So we can see an increase in skilled birth attendants and also an increase in antenatal care compared to 2007, which is very good and very remarkable. Next slide, please. But how does that translate now to reduction of maternal mortality? Unfortunately, there's no corresponding decrease in maternal mortality despite increase in skilled birth attendants, increase in antenatal care, 4 visits increasing, first visit in the first trimester increasing, but the maternal mortality rate, much as it has declined from 276 to 186, that is a 33% reduction. But statistically, it is just marginally significant. If we look at the provinces, this was also highlighted in the morning. All the provinces are showing some decline, but the decline again, if we look at it statistically, it is not significant. So this is a very worrying finding. And we are anticipating that probably our quality of the skilled birth attendants is not as good. And also the quality of our antenatal care that is being provided is not as good. As such, next slide, please. We have some recommendations, but before I go to the recommendations on this area, let's also look at family planning. The in-depth analysis has found out that risk factors of maternal mortality indicates that women who had a prior pregnancy loss, we saw that in the morning, are at a greater risk of maternal mortality. Again, women who have never used a family planning method are also more likely to die due to obstetric complications. The message is clear here. If we do family planning, we prevent pregnancy in the first place. And if pregnancy doesn't take place, then there's no need to go through pregnancy loss, or whether induced or otherwise. And also, there will not be obstetric complications because pregnancy is not there in the first place. So we have come up with 3 recommendations. The first one is that to enhance family planning in this country, we need a functional integration of the Population Welfare Department and the Department of Health. If these 2 are well integrated, we will have a good force to provide family planning services, and we will reach out to a lot of women in this country, and that would help us to reduce maternal mortality. Again, contraception commodity security. If there are no commodities, then there is no family planning program. Clients would go to health facilities, but if contraceptives are not there, then they will go back disappointed. So as much as possible, we are recommending that we need to make sure that we have commodities in the health facilities for family planning so that women can access the commodities whenever they need them. Again, we'd had a discussion on this involvement of men. Decision-making is done by men at community level. If we leave them out, nothing is going to move. We need to have innovative ways of making sure that men are taken on board and they are part of all that we are doing here so that we reduce the maternal mortality. Again, we also need to work hard on demand generation. If people don't know about services that are being provided, then they will not come to get those services. We need to have a robust demand generation a service that would ensure that everybody is aware of where to get services and they access the services when they need them. We also looked at how abortions are contributing to maternal mortality ratios. And according to the Pakistan Maternal Mortality Survey 2019, we have seen that the number of induced abortions were less than that we actually, they were far less than it may actually be the actual situation. It is difficult always to estimate abortions because not all people come out associating themselves that they had an induced abortion. So it is a problem globally. So women having an induced abortion compared to those having a live birth in the same time period revealed that urban women would have more access to abortion services those that are highly educated would have access to abortion services, and those in the higher income strata would also have access to abortion services. Even after controlling for possible confounders and also also doing further analysis, it was found that these factors did not change. Where you live, the level of education, and also your income level had some impact on whether you can access abortion services or not. So women having an unwanted pregnancy, those having access to health services are more likely to get their pregnancy terminated compared to those that don't have access to health services. For this, we would like to recommend some policy discussion on effective coverage of family planning services, access to safe post-abortion care services at all levels. If I go to a BHU, I should be able to be assisted if I need safe abortion services, post-abortion care. If the BHU cannot be able to provide me this care, they should be able to refer me to where I can be given this care. And counseling to women having an abortion is also important because they are going through a lot and they need more information and they need more support. We also discussed We also had a discussion on perinatal mortality, how it is contributing to maternal mortality ratios. And we found that perinatal mortality rate is high in Pakistan. And the risk factors for maternal and perinatal mortality, they often overlap. And any interventions to reduce maternal mortality will also result in preventing stillbirth and also early neonatal deaths. The wealth and geographic inequities significantly affect perinatal mortality, and mothers' education and education level of the head of the household are also contributing factors affecting perinatal mortality. As such, we also came up with the following policy suggestions. We need to provide quality of care for mothers and newborns. As you can see, the direct relationship between the maternal care to the neonatal care. If we provide quality of care to the mother, then we'll also save the baby. So there's need for quality of care for mothers and newborns. Next slide, please. And also institutionalization of the labor care guide. The labor care guide will help us to monitor labor and identify problems while the woman is in labor. And this would help us to save the woman's baby, as well, the woman's life, as well as the life of the neonate. So if we can institutionalize this labor guide, it can also contribute to reduction of maternal mortality. Promotion of early essential newborn care in both facilities and also at community level, very important factor. We would recommend also to ensure that this is rolled out countrywide to ensure that we provide the care that our neonates need at facility level, and we also have them in the communities, and then we also reduce the stillbirths. Then we also had a discussion on maternal health services utilization and how they are contributing to maternal mortality ratio. And the Maternal Mortality Survey 2019 highlights the importance of improving the quality of reproductive health care in Pakistan. Only about 20% of pregnant women reported that they received an ideal antenatal care, and this ideal is defined as that which provide 4 or more visits done by a skilled health provider. The first visit being in the first trimester to identify problems as early as possible. Visits including lab work and dietary advice being provided, at least a check of hemoglobin. And again, women living in urban areas and those in high wealth quintiles were more likely to receive ideal antenatal care and skilled birth attendance, as well as proper postnatal care. Policy suggestions for this area: if we can operationalize comprehensive guidelines on antenatal care, intrapartum care, and also postnatal care as a continuum, then we'll be looking after women pre-pregnancy, while they are pregnant, in labor, as well as postnatal. And we'll make sure that as we look after them through the continuum, we are identifying problems and solving the problems to avoid maternal deaths. We are also suggesting scaling up of maternal perinatal death surveillance and response system at facility and community levels. Currently, this is done in very few hospitals in our country. If we can scale up this intervention, then we will be able to notify maternal deaths in time, review the maternal deaths, what contributed to those maternal deaths, what could have been avoided, so that next time it doesn't happen again. Specifically contextualized at that particular facility based on the conditions of that particular facility. This has to go along with what Dr. Paritha mentioned this morning, notification of maternal deaths. If we have mandatory notification of maternal deaths, everybody would be liable to report if a maternal death happens. And if that happens, then we'll be able to discuss around the issues that contributed to that maternal death in order that next time it should not happen again. Again, we need a legal framework for this because this is a sensitive issue. If a maternal death occurs and I am found to be at fault, will I get litigation? Is that necessary? Because the MPDSR is there so that we can review circumstances surrounding this death and we improve next time. But if I get some litigation, then next time my friend will not report because they will be afraid that something will happen to them if that is reported. So we are strongly advocating for notification of maternal deaths as mandatory so that they are reviewed and we find out circumstances surrounding those deaths. Adoption of quality of care standards at all levels, as we have already discussed in the other areas, is also continuing to be advocated here. We also had a discussion on cesarean sections. Cesarean sections in Pakistan, 22%, higher than the global average of 21%. Cesarean sections are high amongst those women living in urban areas and those in higher income groups and women who are educated. We heard from the presenter this morning that those cesarean sections in the private sector are higher than in the public sector. Not sure whether the private sector probably is looking at a greater number of women than the public sector, or those that go to the private sector have a higher income so they can afford a cesarean section. A number of contributing factors to this. But the good news is that data has also suggested that women having medical indications for cesarean sections are also more likely to go through this procedure regardless of their socioeconomic status or residence. So the poor people, despite the fact that they can not afford probably health services, but if they come early to the health facility and it is required that they get a cesarean section, they get it despite their socioeconomic status. So that is a good finding. Nonetheless, there's also need to further investigate the reasons for the cesarean section and to establish if these are not being carried out unnecessarily. sometimes people demand cesarean section when they don't actually need it. We know the risks, so there's need to have some rationalization of conducting of cesarean section. So in this case, we are suggesting institutionalization of the WHO recommended Robson tool for optimal use of cesarean section. This tool has categorized all women into different categories, about 8 to 10 categories. So we would be able to evaluate ourselves at a health facility, whether we are doing our cesarean sections to primogravidas, or which group under the Robson grouping of optimal use of cesarean section, we are doing our cesarean sections more, and then we would be able to realize whether we are optimizing the use of cesarean section or we are doing some of the cesarean section unnecessarily. Effective coverage of comprehensive emergency obstetric and neonatal care services. This is also very necessary, starting from the basic obstetric care services. But whenever there's an emergency, there's need to make sure that the women get the care that they need in that emergency. Introduction of postpartum family planning in all hospitals is also important. This is the easiest way to get women once they come for postpartum care. We also offer family planning. They are coming for under 5 clinic. We also offer family planning, and we reach out to more of them. Then the next area, this is the last. This is the last. Thank you. Thank you very much for your attention. I hope we will be able to isolate the most important policy recommendations and implement them to a large scale. Thank you so much.
Thank you very much, Ms. Ellen, for providing us such an insightful review of the 5 different areas of maternal mortality and providing the key policy recommendations for women of Pakistan. Now, as per the schedule, we would have a 15-minute question-answer session, which would be capitulating this whole national workshop, which will be followed by a panel discussion. But 15 minutes question-answer session, please. If anyone wants to ask a question, please raise your hand in person, or people listening to us or seeing us on Zoom.
I think Dr. Machine has to leave, so maybe we will have a panel discussion along with questions, because panel discussion में ज़रूरी नहीं है कि हम लोग discuss करें. We have a team of yeah. So sir, आपको थोड़ा सा brief कर दें. I'll moderate, but panel discussion का ज़रा बता दें, and we can start. Dr. Fareed को आप करने दें. तो साथ ही question जिनके हैं, they can come up with a question.
So actually, the idea of the panel discussion was that, to basically go recall what we have learned this morning. All morning we have been talking about like what are the issues and problems, and then of course, the summary of these and including the policy implications. So idea of panel discussion is to give us like concrete suggestions, suggestions which will be, implemented by the government, should be implemented by the government. Not just like, discussion for the sake of discussion, but if you have questions about something, of course, so yeah, so we can hopefully when we leave this evening, we have, maybe 5 or 6 points which we can give to Dr. Machine, and she maybe take it to with her, So that's what I think. Hand over to.
Thank you. And the panel discussion will be among most of the people sitting on the table. Dr. Nabila Ali, she started her public health journey from Health Services Academy. Now at the height of her career, she's again in Health Services Academy, which means she's a true friend of HSA. So usually people fly away and then they rarely come back. But she is a real role model for MNCH in Pakistan. A lot of projects came to Pakistan because of her efforts, and the things which you saw, the 40% improvement in maternal mortality, it's not because of something which was just by chance. There were a lot of projects done by a lot of partners. Dr. Samina Naeem भी हमारे साथ हैं शुरू से. Dr. Farid Middat को आप सब ने सुन भी लिया और देख भी लिया. ये हमारा जो this was the effort of his stature के जिसमें first time Pakistan maternal mortality and morbidity survey हुआ है. It was a part of PDHS in 2006-07, but this is the solo standalone survey. डॉक्टर नशीन हमेशा से HSA की फ्रेंड रही हैं, डॉक्टर हैं, लेकिन उसके बावजूद इन असेंबली के अंदर भी हर जगह हेल्थ की बात करती हैं, और हेल्थ में जो हमारी काफ़ी सारी इंक्रीजेस हुई हैं बजट्स में, वो इनकी वजह से हैं. तो she always has a very kind heart for HSA. Aisha was one of the main जो इसके कंट्रीब्यूटर निप्स ने लीड किया था. डॉक्टर अमरीन है, डॉक्टर नबीला ज़का है. So we will be discussing some of the key findings. लेकिन मेरा ख्याल है I will take forward from the policy implication which Ellen described one by one. I'll ask first Dr. Nabila, the way she has seen in the last maybe 15 years or 20 years, she has seen the whole spectrum. ये लगती ज्यादा है, इनकी इतनी एज है नहीं, 20-22 साल जो है इन्होंने इसमें काम किया हुआ है. तो इन्होंने whatever she has done, some policy implication of your 2 decades of interventions in Pakistan, if you can narrate, so that the future, there are 2 kind of people sitting in this room. One are practitioners and one are future public health professionals. जो back seats पे अभी बैठे हैं, इन्होंने आज से 5 साल के बाद front की seats पे बैठना है. तो इनके लिए ये students हैं हमारे HSA के, मेरे first batch है. They have just entered into this, and we have a habit of not doing this kind of meetings in 5-star hotels in HSA, because HSA के students को फायदा होता है, वहाँ पे जरा जाना आना मुश्किल होता है. It's very, very, very good for them to learn. So the whole policy perspective moving on, and now post-COVID, that is important. Post-COVID, how will we encourage the mothers to come back to the facilities again when we were telling them in the COVID not to come to the facility?
Thank you very much, Dr. Fareed, and you're very kind. You said 20 years. It's 35 years now. Time flies, but I felt very young, so it's good. So, but thank you very much, and I want to congratulate. Thank you very much. I want to congratulate Health Services Academy and WHO for organizing this extremely important workshop. And with Dr. Fareed Middat around, I can imagine, how much focus you will have on maternal mortality and maternal health and child health. I think it's a journey, Dr. Shahzad, that Dr. Fareed Middat, myself, and many other colleagues, we started together. And at that time, maternal health was there on the radar, but newborn health was not there at all. So, but we all understand that newborn mortality was so high. In Pakistan, it was the highest. I'm talking of early 20s and late 90s. That is when there was realization that we need to have community midwives, because newborns are dying and mothers die during childbirth unnecessarily. And the births that take place at home, the mothers' lives can be saved. So these are needless deaths that are happening. So with that realization, and I'm not going to talk about the 3 delays, everybody understands them, but that is when Safe Motherhood Alliance came into existence. It was looking at the situation, and Dr. Fareed Middat sitting here, I think we need to give him a big hand, was the pioneer who came up with the idea. And Dr. Nausheen, in my office, I still remember in 2005, we were 5 people, Dr. Amanullah, myself, Dr. Fareed, and a couple of others, Dr. Mubashir, and yeah. So we all got together and we pulled out 5,000 rupees from our pocket, which was a big thing at that time. And we got registered the White Ribbon Alliance and the Safe Motherhood movement. It started in Pakistan earlier, but it was then registered there, realizing that there are many gaps, both on the supply side and on the demand side, where we have taken many steps in the right direction in the form of community midwifery program, introduction of that, of community midwives as skilled birth attendants who would provide services at the grassroots level, the lady health workers program, and then the MNCH, National MNCH program came into existence. Dr. Fareed, if you remember, in 2003, a maternal mortality conference was held, madam. And that's when Mr. Shaukat Aziz at that time, he said, what do you want? And we said a maternal newborn child health program at the national level. So that's how it started. And by then, as part of the project that I was managing, PAMAN project, Pakistan Initiative for Mothers and Newborns, we had already trained 2,000 community midwives. So that led the way, and with UNFPA contributions, with Dr. Fareed and others, like public health people at that time, we all tried our level best to have skilled birth attendants, and also promoted institutional deliveries. There was a lot of advocacy done. There was, Karachi Declaration that came into talking of policy implications. So government has always been very, very responsive in taking several steps. But where we fail is the implementation. And we have realized that still today, madam, with due respect, we have supply side gaps. We have unmet need. We do not have, 100% gynecologists and obstetricians providing services at the district level. So the vacant positions, if you look at that, and if you carry out an analysis, because if you have to reduce maternal mortality or newborn mortality, lady health workers can contribute, community midwives can contribute, but the lives will be saved, at a level where you have blood transfusion services, where you have cesarean section services, where the complications of childbirth and delivery can be handled. And that is where we fail even today. I'm not talking of far back, I think 5 years back, the situation in one of the province was that 75% of specialist positions were lying vacant. So who is going to save the mother's life, even if she comes to the district headquarter hospital? And we should all remember one figure, 155 districts in Pakistan. Is it a big deal that we should have 155 gynecologists or obstetrician and newborn care pediatricians, there, and a cesarean to the, the anesthesia, anesthetists, So these are 3 critical specialties which are required in just 155 district headquarter hospitals, if not more. So I'm not saying this because Dr. Nabila Zaka is sitting here, but quality of care is so important. We look at these numbers starting from 500, then we said 400 maternal mortality ratio, then we said 240, now 187, 260, and what is it, 186. But where is the quality of care in all of this? Why do we, the ideal should be that if maternal mortality is reducing, newborn mortality, perinatal mortality should also be reducing. But why do we see, that a very slow progress in that? Because of quality of care. And that is where quality of care framework in this very room, through the Madam Health and Population Think Tank Roundtable, Dr. Babar was at that time the convener of that. A quality of care framework was introduced where UNICEF took lead in that. I think we need to implement that. We are talking of our solutions now. We need to have human resource available at the place where they're required. There are so many pediatricians in provinces, but they are only sitting in the cosmopolitan cities and not in the rural areas. And whereas 90% or so population is, predominantly 70% of the any district is rural area, So we need to have this in mind, that 1, human resource, number 2, supplies, Still, Dr. Shahzad, you do a lot of surveys, you do a lot of impact evaluations. The contraceptives, 90% are their stockouts. I'm not going to name the provinces just because they were not procured on time. They are not there. So no product, no program. Somebody, I think, Ellen, you just mentioned that product has to be there. Madam, you'll be surprised that there was no cost center for in-service training program in the budget, regular budget. So a lot of advocacy was done, and then the government realized that we can't rely on donors or development partners for, piecemeal trainings here and there. The in-service training program budget was added. So I want to congratulate government, for taking that step forward, for taking those steps which are like in hiding. Somebody will think, what has that got to do with maternal mortality? But unless there is in-service training program, we as medical students do not get trained in so many things that we realize that in practice that should have been, the major focus in our medical colleges. So I'm not going to go into detail. There's a lot that I can talk about, but 3 things are extremely important. One is behavior change. The other is supply side, which is easier, which the governments can provide. There should be no stockouts. There should be human resource available. And I never ask for more budgets. It is the realistic and rationalization of the budget that is required. So that is where we have to, provide services to the masses. So there are 2-3 things that I really want to talk about, and that is governance, because I wear health system strengthening hat. Unless we have good planning backed up by realistic budgets and accountability. And accountability. How many, Assalamu alaikum, madam, how are you? How many times we think of accountability? What are community midwives doing? What are lady health workers doing? What are the gynecologists doing? Infection prevention and control, even if you give them trainings, there are autoclaves, but still they put dirty instruments in a dish and just wash it under running water. And the autoclaves are there. We can't blame government in this. It's a shared responsibility, and each one of us at our level, we have to contribute to this. I'll stop here because there are many other panelists. Thank you, sir.
I think Babar can add in quality of care a lot, specifically the perceived quality of care. The issue of MNCH quality of care is huge in this country. That's why people don't go to the government sector. Some of your own experiences in Aga Khan and then in HSA. Babar is also an ex-professor of HSA and currently visiting an adjunct professor of HSA. He will be taking your classes, some of the sessions. Over to you, Babar.
Thank you, Shahzad. I'll be very quick. Why people, and this is a point for the policy level thought process, which is to be taken up. Why people resort to private sector, why we all of us sitting in this room prefer and like to go to the private sector, because of the one word, madam, this was coined in by WHO in 2000, and that word was responsiveness. And when we unpack this word of responsiveness, there are lots of things which includes, of course, the critical element and central position jiski hai wo quality of care. Private sector has the responsiveness, the respect, the regard, the integrity of the patient, the dignity of the patient, and the overall environment that people get in the private sector. That's why to go. And one study I remember from the early 90s by the World Bank in Pakistan, in which they cite that even the poorest population, poorest household in Pakistan, who cannot afford to go to private hospital or private healthcare, even their first preference would be कि हम किसी तरह private healthcare में चले जाएं. So what is that niche or the edge that private sector has got? देखिए, public sector has been the largest financier of health system. It's the custodian of the health system. but as the policymaker and the policy way forward should be that private sector should be taken into the mainstream, and the good things and the lessons which are there to learn from the private sector has to be replicated in the public sector. Some of the initiatives of the present government are geared up to improve the state of responsiveness and readiness of the health system. And we have recently seen people availing, millions of people now availing the health protection and safety net introduced by the government. But once a woman reaches the health facility, the public sector health facility with that card, Sehat Sahulat card, then the story on the other side starts. If the state of responsiveness and respect and dignity is not there, this initiative may not actually deliver. So that is the area where we need to work further. Thank you.
Babar, and I think you can understand there is a Sunday is a very special day in Pakistan because of a political, turmoil. And Dr. Nosheen still sitting here and receiving messages from PM House and others, and she has to go. But before going, I will request her to say a few words. And of course, we will compile a policy brief and submit to the government for different. And I also welcome Dr. Sabina Durrani. She is the DG of Population at the Federal Ministry and NHSA alumni. So वो हमें जरा proudly बताना पड़ता है. ठीक है.
जी, बिस्मिल्लाहिर्रहमानिर्रहीम. All the worthy participants, सारे माशाल्लाह से सारे I think बिल्कुल जो इस relevant maternal mortality से है, उसके बिल्कुल आपके पास most expert और सबसे relevant gathering आज यहाँ पे मौजूद है. सबको अस्सलाम वालेकुम. I think this is a very good initiative और इसके बारे में जितनी भी बात की जाए और जितने भी discussions हो, especially आप जैसे experts के साथ उतना ही कम है. I would just like to share few of the government initiatives which have been taken recently. क्योंकि obviously maternal mortality के सारी आपने technical aspects वगैरह discuss की और उसके अंदर एलन की बहुत अच्छी policy recommendations थी, but obviously there are certain root causes जिसकी वजह से हमारे मुल्क में MMR is so high. And मैं एक एक करके बात करूंगी. जैसे सबसे पहले malnutrition. मदर्स का न्यूट्रिशनल स्टेटस इतना पुअर होता है कि ऑब्वियसली वो छोटा मोटा कोई इवेंट या एपिसोड होता है उनके साथ, तो वो डिलीवरी के टाइम पे उसको वो फेस नहीं कर सकती और हम उसकी ज़ाहिर सीरियसनेस की तरफ चले जाते हैं. तो इसके लिए जो गवर्नमेंट का इनिशिएटिव है उसके अंदर मदर्स के लिए स्पेशली एहसास नशो नुमा, ये मदर्स एंड चिल्ड्रन के लिए ये शुरू किया गया है. और इसके अंदर कंडीशनल कैश ट्रांसफर्स हैं स्पेशली टू द एक्सपेक्टिंग मदर्स, ताकि वो अपनी न्यूट्रिशनल स्टेटस को जो है वो बेहतर कर सकें. तो दिस इज द एहसास नशोनुमा प्रोग्राम. उसके अलावा जो हेल्थ कार्ड्स अब कल ही 31 मार्च को हेल्थ कार्ड्स जो हैं वो पूरे पंजाब में यूनिवर्सल हो गए हैं. दैट मीन्स के ऑल द डिस्ट्रिक्ट्स 36 डिस्ट्रिक्ट्स ऑफ पंजाब, उनमें everybody, the whole population of Punjab has got the health cards by 31st March. और उसके अंदर ये ज़ाहिर इंस्टीट्यूशनल डिलीवरीज जो हैं वो कवर्ड हैं और एंटीनेटल विजिट्स भी उसके अंदर शामिल हैं. और तो इससे मैं समझती हूँ कि थोड़ा सा फर्क पड़ेगा, क्योंकि वो लोग जो नहीं पहुंच सकते थे हॉस्पिटल्स तक या डिलीवरीज इंस्टीट्यूशनल नहीं करा सकते थे, अब उनके पास जब ये अपॉर्चुनिटी होगी तो डेफिनेटली वो उसको अवेल करेंगे. और उसके अंदर आई थिंक 3 या कोई एंटीनेटल विजिट्स भी इंक्लूडेड हैं. तो और इसमें प्राइवेट हॉस्पिटल्स जो हैं वो चूंकि ऑन पैनल हैं और दूर दराज के इलाकों में जहाँ पे कुछ ऐसे शहर थे जहाँ पे नहीं कोई हमारे पास THQs या DHQs में इतनी फैसिलिटीज नहीं थी, वहाँ पर अब चूंकि हेल्थ कार्ड्स में 90% से ज़्यादा प्राइवेट हॉस्पिटल्स एम्पैनल्ड हैं और ये छोटे छोटे शहरों में गुड क्वालिटी हॉस्पिटल्स हैं. और क्योंकि सर्टेन स्टैंडर्ड्स रखे गए थे हेल्थ कार्ड के पैनल पे आने के लिए, तो जो उन स्टैंडर्ड्स को मीट करे वो प्राइवेट हॉस्पिटल्स जो हैं वो इंक्लूडेड हैं. तो डेफिनेटली ये छोटे शहरों में और जहाँ पर ज़्यादा ये चीज़ें थी वहाँ पर इनकी प्रेजेंस से हेल्थ कार्ड जो है वो डेफिनेटली मदर्स को फैसिलिटेट करेगा. उसके अलावा जो फोकस इस वक्त चूँकि फेडरल गवर्नमेंट के नीचे ICT के इंस्टीट्यूशंस आते हैं, तो 13 नई फैसिलिटीज़ जो हैं वो इस्लामाबाद में बिल्ड की जा रही हैं और उन सब के अंदर जो है वो मैटरनल हेल्थ का एस्पेक्ट है. जितने BHUs ऑलरेडी एग्जिस्टिंग थे 16 के करीब थे, उनमें तो MCH सेंटर्स जो हैं उनको अपग्रेड वेल बेबी क्लिनिक के नाम से और अलग मतलब है कि BHU से अलग साइड पे हट के MCH सेंटर बन रहा है, जहाँ पे अब इंशाल्लाह ताला ये डिलीवरीज की सहूलत होगी और डॉक्टर्स वहाँ पे मौजूद होंगी। और कम्युनिटी हेल्थ सेंटर्स जो हैं वो इस्लामाबाद में बनाए जा रहे हैं।
तुम्हारा ही है, मेरा तो नहीं है। मैं तो नहीं बनाती थी ये, अयाज बनाता था। अरे हर जगह शॉपिंग से जाकर नहीं है वो लग रहा है।
I repeat, the participants on the Zoom, please send us the questions in the chat box, please.
I'm sorry for creating this
जी बिस्मिल्लाहिर्रहमानिर्रहीम। सिलसिला वहीं से शुरू करते हैं जहाँ से मुनक़ते हुआ था। अच्छा, एवरीवन हैड अ चांस टू से फ्यू वर्ड्स। अभी तो दुरानी चली गई। अच्छा, आई थिंक शी इज गोइंग टू बी बैक। तो नबीला, आप कुछ कहना चाहेंगी आज के हवाले से और इस इम्पोर्टेंट इवेंट के हवाले से, प्लीज।
नहीं, खुशी की बात है कि नहीं है खुशी की बात, लेकिन many years before this stable emergency obstetric and we like you know कि नहीं अगर लेबर रूम होगा, अगर डॉक्टर होगी, अगर ब्लड बैंक होगा, we would save lives। हाँ, और अब तकरीबन मतलब चले सारे डिस्ट्रिक्ट्स में नहीं तो आधे डिस्ट्रिक्ट्स में जरूर है ये सब कुछ। लेकिन हमने कभी देखा ही नहीं कि हमारे पास जो पेशेंट एडमिट होता है उसका आउटकम क्या है। वो माँ बची के नहीं, वो बच्चा बचा के नहीं, सब रिपोर्ट नहीं होता। आपके लेवल पे डेफिनेटली होगा, लेकिन DHIS में भी लोग नहीं कोई अपना डाटा देखता कि ये सब कुछ वहाँ है। अभी सुबह बात हो रही थी ना कि अभी हम सिर्फ सर्वे का क्यों वेट करते हैं, हमें ये रेगुलर इंफॉर्मेशन भी चाहिए। लेकिन रेगुलर इंफॉर्मेशन आती है, देखता ही कोई नहीं है। ये DHIS से आप अपने मोर्टेलिटी रेट सारे निकाल सकते हैं, आप अपने EMOC सिग्नल फंक्शन सारे निकाल सकते हैं। आपको नज़र भी आता है कि किन डिस्ट्रिक्ट्स में ज़्यादा डेथ्स हो रही हैं, और एज अ प्रोपोर्शन डिलीवरीज के कितनी डेथ्स हैं, स्टिल बर्थ कितनी है, न्यूबॉर्न डेथ्स कितनी है, वो सब इंफॉर्मेशन है। लेकिन हमने वो कल्चर ही डेवलप नहीं किया कि हम अपना डाटा देखें और उससे सीखें। जो एवरेज है ना, वो शायद देखे वो आपको नहीं रिलेट करती होगी, मुझे नहीं रिलेट करती होगी, लेकिन अपना डाटा तो हर एक को रिलेट करता है। और वही बात है कि when we were looking at the policy implications, अगर हम अपने डाटा को यूज करना शुरू करें, अपनी क्वालिटी आप डाटा के बगैर नहीं कर सकते, बिकॉज यू नीड एन ऑब्जेक्टिव एविडेंस कि आपने किसके अगेंस्ट अपना काम करना है, अपनी प्रोग्रेस गेज करनी है। तो डाटा इज द फर्स्ट थिंग, और फिर ये कि नहीं आप कंसर्टेड एफर्ट करो। MPDSR भी उसका एक बड़ा पीस है। जब तक आप वो नहीं करेंगे, ना हम मैटरनल आउटकम्स इम्प्रूव कर सकते हैं, ना हम न्यूबॉर्न्स की आउटकम्स इम्प्रूव कर सकते हैं। ओवर टू यू डॉक्टर सबीना, आपकी लीडरशिप ने हमें बहुत हौसला दिया है और इंस्पिरेशन भी दी है।
सुनना चाहती हूँ पहले आप लोगों से, मैं जरा क्वेश्चन सुनना चाहती हूँ कि व्हाट एग्जैक्टली द इस वक्त एसेंस क्या चल रहा है, सो दैट आई कैन रिस्पॉन्ड अकॉर्डिंगली। और जो फिर हम गवर्नमेंट में जो भी हमारी पॉलिसीज हैं या जो आगे हम, तो इस टाइम पर भी बहुत सारी चेंजेस हो रही है लास्ट मोमेंट पर जिसको, और मैं अब आपको कुछ बताना भी चाहूँगी, किसी पर 2-4 सवाल लेके बना।
Okay, so one good news that I want to give before we proceed to questions and answers is what Dr. Nabila Ali mentioned about the vision on quality of care. So now it has gelled into a national strategic framework with monitoring evaluation indicators, with very concrete steps what to do and how the federal government and provincial governments and the other stakeholders, what part they can play. So thanks to leadership of Dr. Sabina, he has been the forerunner of that, and we hope that in near future we will start its implementation with all of your support. Thank you.
Acha, I think it's more like a session where we can have, a few words from everyone. Dr. Mariam, आप कुछ कहना चाहेंगी? Dr. Kutsia, would you like to say something?
First of all, thank you very much to Dr. Fareed for organizing the school work around maternal mortality. जैसे डॉक्टर नबीला ने कहा कि डेटा कोई देखता नहीं है, हमारे पास PDHS 1991 से ऑनवर्ड हो रहा है, and people like us जो academics में हैं, जो research में हैं, we keep on doing secondary analysis, regression, trends and all those. We do it, we publish it in a good journal, and we are very happy कि हमारा impact factor बड़ा high, personal impact factor और institutional achievement हो गई है. So having a forum, first of all, having a forum like this where we have students from the public health field as well, who are learning about what is happening and what has happened so far over the past years is a good opportunity. Second, जो मैं डॉक्टर सबीना से मेरा एक particular request आप कह सकते हैं कि maybe she can take a lead in this कि एक कोई ऐसा public platform, be it from the ministry के forum से, or be it some kind of a newsletter which is initiated जो कि maybe आम English में और आम उर्दू में लिखा हुआ हो, और वो actually health workers के lower cadres तक भी जा रहा हो, क्योंकि ये हो रहा है, ये issues हैं जिसकी वजह से माँ की मौत होती है, जिसकी वजह से उसको morbidity होती है या उसको issues होते हैं. So policy briefs हम बनाते हैं policy makers के लिए, लेकिन मुझे ये लगता है कि ये एक element missing है कि हम जो other health workers, allied cadres of health workers हैं, उनको हम miss out कर रहे हैं. And maybe we need to start taking a kind of a very 360-degree approach to it. We don't just focus on nurses, on midwives, on obstetricians, on doctors. इन्होंने ही शायद maternal mortality कम करनी है. It's contrary. If you go to the field, it's contrary to that. It's not the doctors, it's not the midwives. It is every health worker, चाहे वो pharmacy में बैठा है, चाहे वो कोई technician है या diagnostics के अंदर काम कर रहा है. So that's one thing which I feel is missing, and I would really like कि उसके ऊपर अगर आप कोई initiative हो, which you see in the future, or if there is something which can be started on that. Thank you.
Thanks very much, Dr. Mariam. Ellen, I would request you to say a few words if you'd like to.
Just to say thank you for the opportunity. It has been a very good meeting because it was based on data. As Dr. Nabila has said, data is very important. So, we are happy that Dr. Nabila has start here today. Just to say, during the presentation, of course, data was not mentioned, but probably as we are studying for the policy recommendation, we will also include the.
Okay, thanks very much. Dr. Kutsia, आपसे रिक्वेस्ट करूंगा प्लीज.
थैंक यू. सबसे पहले तो आप सबका शुक्रिया हेल्थ सर्विसेज एकेडमी का, नेप्स का, for giving this opportunity to WHO to partner on this very important topic. Dr. Fareed का स्पेशल थैंक्स, उन्होंने सबको आई थिंक बहुत ही thoroughly गाइड किया और बहुत अच्छे से हमें इस इवेंट के लिए प्रिपेयर किया. एक कमेंट मुझे अभी मिला है हमारे आई थिंक ऑनलाइन पार्टिसिपेंट्स में से. आई जस्ट वांटेड टू रीड दैट आउट बिफोर मैं कोई बात अपने से कहूँ. I want to add that KP has introduced highly paid salary packages for doctors working in far-flung areas and independent monitoring unit to ensure the staff presence and quality of care. But still many seats are vacant, and so no staff in those areas. I think mobile service unit that would include a vehicle with ultrasound plus antenatal facilities and delivery plus an ambulance for taking the lady well in time could be an option. Another suggestion is an COC sort of an arrangement for data collection, management and leadership of the highest
people like ministers and chief secretaries. This was a comment from Dr. Farina Faisal. I think she's part of Population Welfare Department in KP. So this has come from there. So मैं अपने end से ये कहना चाह रही थी कि मुझे feel हो रहा था that I think whenever we talk about data, there are very less surprises. Generally एक ही तरह की results होते हैं और पोस्ट बड़े प्रिडिक्टेबल भी होते हैं, बहुत कम ऐसे वो होते हैं जो कि आप सोचें तो आपको ये फील होता है जैसे हम पिछले 2-3 डेकेड से एक ही जैसी बातें कर रहे हैं इन एवरी सिटिंग एंड नथिंग चेंजेस। लेकिन जो पर्सपेक्टिव मैं समझती हूँ हमें रखना चाहिए वो ये है कि एटलीस्ट स्टेटस को एक्सेप्ट करना और उसके ऊपर बात ही ना करना, आई थिंक वो भी कोई रैशनल अप्रोच नहीं है। सो ऑल्दो हमें बहुत कम प्रोग्रेस नज़र आती है, बहुत स्लगिश प्रोग्रेस नज़र आती है, लेकिन कीपिंग द एजेंडा अलाइव एंड एटलीस्ट मेकिंग द एफर्ट दैट वी कैन पॉसिबली डू एट आवर एंड एट आवर लेवल, आई थिंक दैट शुड बी द अप्रोच दैट एवरी पब्लिक हेल्थ प्रोफेशनल शुड अडॉप्ट। थैंक यू
जी। डॉक्टर सबीना
जी, थैंक यू सो मच जी, थैंक यू सो मच फॉर इनवाइटिंग मी। और मेरे साथ इतने बड़े बड़े लोग बैठे हैं, मेरी टीचर भी बैठी हुई है, तो मुझे समझ में नहीं, मेरे टीचर उनसे मैं पूछती होती तो मुझे समझ नहीं आता कि मैं आज क्या बोलूँ। बट एनीवेज कुछ जी मैं आप लोगों के साथ शेयर करूँगी। पहले मैं पॉपुलेशन पर आऊँगी और फिर मैं जो आपके सॉर्टेड क्वेश्चन है उसको मैं, बिकॉज सब कुछ जो आप बात कर रही हैं सब कुछ हो रहा है, आई थिंक दिस दैट के वी नीड टू स्ट्रीमलाइन ऑल दैट। ये एक मिसिंग लिंक है हमारे पास। काम मैं भी कर रही हूँ, आप भी कर रही हो, लेकिन मुझे नहीं पता कि मैं क्या कर रही हूँ और आपको और इन लोगों को नहीं पता। So that's the missing link, और this is not a new thing. We are facing this issue since now. Madam is here, आप लोगों को बताइए कि कितना हमारे लिए मुश्किल है। Now coming back to the, because I'm looking after both the population welfare program and RMNCH, because these ministry feels that ये दोनों चीजें interlinked है. You cannot separate family planning from the maternal and child health. Family planning is not a separate entity, it is a tool to improve the health of the mother and child. यही इसका जो जितना हमें की समझ है। थोड़ा सा जल्दी से बिल्कुल फिक्स आपको दूंगी कि क्या हुआ है उसमें। पॉपुलेशन की बॉडी, पॉपुलेशन मिनिस्ट्री एक बहुत बड़ी मिनिस्ट्री थी, आपके डिवोल्यूशन स्कैटर्ड हो गया, बट अनफॉर्चुनेटली अगर हम देखें तो पॉपुलेशन प्रोविंसेस में जब चली भी गई, पॉपुलेशन इज द नेशनल इशू, इट इज नॉट अ प्रोविंशियल इशू। जब हमने इसको प्रोविंशियल इशू के तौर पे लेना शुरू किया तो ये सारी इशू हमारे लिए आ गए। इन चीज़ों को देखते हुए तो मोटो एक्शन हुआ, सुप्रीम कोर्ट ने उस पर एक्शन लिया, और फिर एक CCI से होती हुई हमारी इन शॉर्ट एक फेडरल टास्क फोर्स जिसको प्रेसिडेंट ऑफ पाकिस्तान लीड कर रहा है, एंड प्रोविंशियल टास्क फोर्स जिसको प्रोविंशियल चीफ मिनिस्टर्स एंड चीफ सेक्रेटरीज ऑल दे आर पार्ट ऑफ दैट। उसके बाद उन्होंने ये किया कि हमने अपना एक नेशनल एक्शन प्लान बनाया, और उसके बाद एक कॉस्टेड एक्शन प्लान बनाया। 8 थीमेटिक एरियाज आइडेंटिफाई हुए कि दीज आर द बेस्ट प्रैक्टिसेस के बेस पर ये 8 थीमेटिक एरियाज अगर हम उसको इन जगहों पे काम करें तो हमारा CPR इंक्रीज हो जाएगा। हमने CPR को इंक्रीज करना था तो हम 34 to 50 ड्यूरिंग द नेक्स्ट 5 years करवाना है, एंड सो ये पार कम करना है, वो जी आप लोगों को मुझसे ज़्यादा पता है। ये सारी चीज़ें हुई। अब इश्यूज में ये आ गए कि पॉलिटिकल कमिटमेंट तो नो डाउट इज वेरी हाई। प्रेसिडेंट ऑफ पाकिस्तान हर उसमें 6 माह के बाद हम उनके पास जाते हैं, एंड ऑल द प्रोविंसेस आर देयर एंड दे विल हैव टू गिव देयर अपडेट्स के व्हाट वी हैव डन सो फार, एंड ऑल द हाई लेवल फोरम दे आर देयर। इसके अलावा हमारे पास एक और फोरम भी है जिसको हम कंट्री एंगेजमेंट वर्किंग ग्रुप के नाम से याद कर रखते हैं। इसलिए 3 months के बाद हमारी मीटिंग होती है, एंड ऑल द प्रोविंशियल हेल्थ एंड प्रोविंशियल फैसिलिटीज आर देयर। So if you want to approve or to discuss anything important, so all the provincial जो आपके रिप्रेजेंटेटिव है they are there, तो वहाँ पर आराम से ये हो सकता है। And this is a forum not only for the government sector, but all the donor, all the INGOs, NGOs, all the stakeholders are there. अभी हम recently, I would like to invite you also. मैं आप लोगों को भी इसमें दावत दूंगी, आज सेंचुरी में मैं भिजवा बताओ कि जी हम लोग कर क्या रहे हैं। अच्छा, अब दूसरा इशू उसमें ये वाला आ गया कि किसी ने इसमें ये कहा कि जो बहुत बड़ा इशू आ रहा है, हम लोग जब अपनी एलोकेशन ऑफ बजट की बात कर रहे हैं, प्रोविंसेस गलती गवर्नमेंट की भी है और गलती डोनर की। अगर हम प्रोविंसेस की बात कर रहे हैं तो हमारी एलोकेशन ऑफ बजट इज दैट बहुत ज़्यादा एलोकेट, जब एक्चुअल यूटिलाइजेशन आती है तो इतनी छोटी सी आती है। अगर हम डोनर की बात करते हैं तो डोनर की एक्टिविटी दे आर नॉट इन लाइन विद आवर एक्शन प्लान। दैट्स द बिग थिंग। मुझे चाहिए, मैंने जी ये चीज़ खरीदनी है, डोनर मुझे पैसा देता है कि तुम ये खरीदो। आई डोंट नीड दैट। मैं पैसे फेंकने के लिए तो मैं खरीद लेती हूँ, बट एक्चुअली आई डोंट नीड दैट। दैट वाज द इशू। फिर हमने क्या किया कि जी हमने जो अपना कॉस्मिक प्लान बनाया उसमें हमने डोनर्स कॉन्फ्रेंस की और उनसे हमने कहा कि जी आप पाकिस्तान उसमें इस टाइम पर भी मोर देन 60% ऑफ द जो बजट है वो गवर्नमेंट ऑफ पाकिस्तान उसको दे रहा है। और ये नहीं है कि जी हम टोटली डिपेंडेंट हैं ऑन आवर डोनर, नो नॉट एट ऑल। अगर हम इसको, मैडम मेरे साथ मुझे यही करेंगी, अगर हम अपने रिसोर्सेज को ही एक सिस्टमैटिक तरीके से अकॉर्डिंगली यूटिलाइज करें तो ट्रस्ट में हमें किसी चीज़ की जरूरत नहीं पड़ेगी। The problem is that कि मुझे हमारी streamlining of my activities, my utilization में है। That's the thing कि जहाँ पर हमने इसको लेना है। फिर वहाँ पर दोनों कॉन्फ्रेंस हुई, उसमें ये डिसीजन हुआ कि जी हम एक ऑपरेशनल फोरम पे एक मीटिंग करके और अपनी एग्जैक्ट आस्क बताए कि जी what exactly we want from JPIGO, from Pathfinder, from WHO, from XYZ, और बता देंगे कि जी ये हमारी डिमांड है। If you want to provide to fulfill our demand in these areas, then we are good. Otherwise, if you don't agree with us or जो मिल जाए तो we don't need that. Simple as that. जी मैंने अपना CPR आगे करवाना है। My biggest issue is my CPR right now. मैंने जी फरीद साहब से मेरी बड़ी डिस्कशन हुई and I'm very much worried. PTHS वाले CPR को हम लोग देख रहे हैं कि जी this is 34. मेरे पास जो ब्यूरो ऑफ स्टैटिस्टिक्स से डाटा आता है दिस इज 42 या 48 समथिंग लाइक दैट। कहाँ पे गलती है, या ये गलत बात कर रहे हैं या वो गलत बात कर रहे हैं। अब उसमें ये वाली बात थी कि जी क्या करें उसमें, तो उनके अपने रीजन होते हैं कि जी डेटा कलेक्शन नहीं ठीक है, वो नहीं है। तो माय क्वेश्चन वाज दैट कि जी या तो फिर आप पाकिस्तान ब्यूरो ऑफ स्टैटिस्टिक्स को बंद करा दें। व्हाई वी आर पेइंग सो मच मनी, इट्स अ टैक्स पेयर मनी। एक डिपार्टमेंट है, अगर उसमें कोई गलत हो रहा है, आप यू फील कि यू आर नॉट गेटिंग द रिक्वायर्ड डाटा फ्रॉम द प्रोविंसेस, इंस्टेड ऑफ अपने उस चीज को अंडर द टेबल दबाने की आप बताएं कि जी ये चीज है, वी विल गो टू द प्रोविंसेस, वी विल आस्क द प्रोविंसेस कि प्लीज आप ये डाटा इसके मुताबिक दे दें। वंस आई विल गेट माय CPR on yearly basis, then only I'll be in a position to set my policies. आपने मुझे CPR दे दिया है 5 साल के लिए, PTHS 5 साल के बाद होगा, मैं 5 साल के लिए किस पर अपना टारगेट में अचीव करूंगी। तो नाउ वी आर वर्किंग ऑन दैट। इनको भी मैंने इन सब लोगों को मैंने इसमें एंगेज किया है कि प्लीज आई नो द प्रॉब्लम, प्लीज नाउ गिव मी द सोल्यूशन। आप मुझे सोल्यूशन बताओगे, प्रॉब्लम हर किसी को पता है, बट द थिंग इज दैट यू आर ऑन द ब्रेन। आप बताएं कि हम इस चीज को एक ईयरली CPR और एक अगर इदारा चल रहा है। अभी इन लोगों ने UNFPA की मदद से वहाँ पे पंजाब में कुछ किया, उन्होंने कोई CPR किया है और अनफॉर्चुनेटली उसमें एक लेवल नीचे ही आ गए हैं। Now I am going to show that in our CWG meeting, if we are doing so well, if my donors and my government, everybody is doing so well, then why there is decline in the CPR? This means that there is some gap, there is some issue है और we need to address that issue. तो उसको भी हमने उसमें करवाना है। दूसरा जी आपने डाटा की बात की, तो डाटा पे अब हम लोगों ने एक चीज़ बना ली है, दिस इज रिसोर्स सेंटर बना है। आप लोग किसी वक्त आप तो लोग आइएगा, सबको मैं इनवाइट कर रही हूँ। उसमें हमारा इसमें ये मकसद था कि दो चीज़ों पे, दो नहीं अलबत्ते 3 चीज़ों पे हमारा इस पे फोकस है। एक जो है जो CCI रिकमेंडेशन थी, जो मैंने बात की, जो CCI रिकमेंडेशन थी, हर एक प्रोविंसेस के लिए अलग अलग एक्टिविटीज थी। मैंने क्या काम करना है, आपने क्या होना है, आप वो जिनके जो काम होते रहेंगे वो उस पे डैशबोर्ड पे आते जा रहे हैं और भी इट विल बी इजी फॉर द फेडरल गवर्नमेंट टू फॉलो अप कि जी किसने कौन सा काम किया है, कुछ रह गया है, और अगर रह गया है तो हम CWG में बताएंगे कि सर मैडम आप ये वाले काम अपने कंटिन्यू करें, जरा जल्दी इसको करवा दीजिएगा। इसके अलावा है हमारे पास एक और टूल भी है CLMIS का, कॉन्सेप्टिव लॉजिस्टिक मैनेजमेंट इंफॉर्मेशन सिस्टम है। वो जब आप खोलेंगे देन यू विल गेट अ क्लियर आइडिया कि जी किस प्रोविंस में किस डिस्ट्रिक्ट में आपका स्टॉक पोजीशन क्या है, कुछ है कि नहीं है, तो वो भी हम उनको और एवरीबडी विल हैव अ क्लियर, आई मीन उसके साथ रीचेबल है, वो देख सकता है, तो उसके बिना पर वो लोग उसको दिखा सकते हैं। तीसरा जो इशू है, जो बहुत इंपॉर्टेंट इशू है, आपकी डुप्लीकेशन ऑफ एक्टिविटी। एक कोई स्ट्रेटेजी बनती है, कोई काम होता है, गवर्नमेंट इज वेरी मच आई मीन इंटरेस्टेड टू डू दैट, आप अलग बनाएंगी, मेरे लिए 4-5 डॉक्यूमेंट आ जाते हैं ट्रेनिंग के, अल्लाह में उस 4-5 डॉक्यूमेंट को मैं किस तरह प्रिंट करूं। नाउ वी हैव रिक्वेस्टेड HSA कि प्लीज विल प्रोवाइड all the material, all the training material, XYZ standardization is that. स्टैंडर्डाइज करेंगे, इसको गवर्नमेंट ऑफ पाकिस्तान अपना छप्पा लगाएगा, चाहे वो इसको कोई भी डोनर इसको इस्तेमाल करेगा, दैट विल बी द डॉक्यूमेंट विच विल बी यूज्ड अक्रॉस द कंट्री। नॉट ये नहीं होगा कि हर एक बंदा अपना अपना जस्ट फंड रिलीज खत्म कराने के लिए वो लोग बनाएंगे। तो प्लीज अगर फंड खत्म करवाना ही है तो वो तो फंड यूटिलाइजेशन इज अ मैटर ऑफ वन नाइट। आप मुझे बताएं मैं एक दिन में, बट देन नेवर आस्क फॉर द क्वालिटी एंड फॉर द आउटकम के इसका क्या होगा। मैं दबादब अपने फंड उसको यूटिलाइज करा दूंगी। तो एक ये वाली चीज मेरे लिए इम्पोर्टेंट थी कि आपको बता दूं। NCOC वाली की जो आपने बात की, इनफैक्ट जो हमारे SAPN साहब हैं उन्होंने ये कहा कि जी लोग कहते हैं कि जी हमें NCOC की तरह कोई मैकेनिज्म डेवलप करना चाहिए फॉर पोलियो और फॉर समथिंग लाइक दैट। तो मैंने उनसे कहा कि इस टाइम पे पॉपुलेशन इज द बिगेस्ट इशू। अगर हमने बनाना भी है तो हम पॉपुलेशन के लिए बनाएंगे। इसमें हमारी प्रेजेंटेशन तैयार है, सब कुछ तैयार है, सिर्फ ये जो पॉलिटिकल टर्मोइल आ गया है, वी आर गोइंग टू द कैबिनेट अब आस्किंग द प्राइम मिनिस्टर कि वो कम से कम मंथली मीटिंग करेगा और वो हर किसी को, वो डॉक्यूमेंट इज रेडी। अल्लाह करे ये रहे, लेकिन इसका जो भी होगा वो चीज़ भी जो हम इसको सीरियसली हम सब ने इसको लेना है। और दूसरी इम्पोर्टेंट बात कि जितनी हम यूटिलाइजेशन करेंगे तो ये भी नहीं कि मैं यूटिलाइजेशन 10 रुपए की करूं और पैसा उसमें मैं एक आना लगाऊं एंड देन आई विल लुक टू द डोनर कि प्लीज मुझे पैसे दे दे, ऐसा नहीं हो सकता है। तो इन चीज़ों को हमने स्ट्रीमलाइन में कराना हमारे लिए बहुत ज़्यादा इम्पोर्टेंट हो गया है। दूसरा इशू जो है, जो DPW और DHO का जो मसला है, यहाँ पर एक इंटीग्रेशन की हम बात कर रहे हैं टू इम्प्रूव मैटरनल एंड चाइल्ड हेल्थ। आप जो भी आप उस पे जाएंगे, यहाँ पे फेडरल लेवल पे दिस वाज जस्ट ए नोटिफिकेशन कि जी हमने एक का पावर दूसरे बंदे को दे दिया, बट नॉट इंटीग्रेशन एट द ग्रासरूट लेवल। नाउ HSA टीम इज वर्किंग ऑन दैट एंड वेरी सून विल डेवलप अ मॉडल जिसको हम ICT में करा देंगे कि जी उस पे इंटीग्रेशन करेंगे DPWO या DHO के ऑफिस का। तो व्हाट विल बी देयर टाइप ऑफ इंटीग्रेशन एट द ऑफिस लेवल, मिड लेवल एंड एट द ग्रासरूट लेवल, ताकि वो डुप्लीकेशन एक्टिविटीज खत्म हो और उसको हम एक दूसरे की एक्टिविटीज को, परफॉर्मेंस को कॉम्प्लीमेंट करें, ना कि हम उसमें एक दूसरे के साथ जिदे लगा कर बैठ जाए। तीसरा एक जो बड़ी इंपॉर्टेंट उस पर हम लोग जा रहे हैं, दिस इज पोस्टपार्टम कॉन्ट्रासेप्शन पर की। मेरा ये ख्याल, ये एक वो एरिया है जिसमें हमने देखिए आपके पास जो है ना पाकिस्तान में आपके पास मोर देन 60% ऑफ द एरिया इज कवर्ड and for around 40% is uncovered area. Now we need to think out of the box कि हम ये 60% को fully functional, fully operationalize कैसे करवा दें और जो remaining 40% है उसको हम कैसे operational करें, public private partnership और whatever the mechanism is that। तो ये वाली चीज़ों को भी हम डोनर को भी बिठा के, गवर्नमेंट को भी बिठा के कि जी हमें आप सोल्यूशन दे, यही वो जगह है जहाँ पर आप CPR को इंक्रीज करोगे और आपका एडिशनल उसमें जो क्लाइंट होगा वो उसमें आए करेगा।
वो एडिशनल सेक्रेटरी साहब ने कल बड़ा अच्छा कहा कि जी इनको जिसके साथ भी अब हम बैठेंगे इंक्लूडिंग द गवर्नमेंट एंड द डोनर, ये ना हो कि वो सिर्फ एक वो कुछ कागजात वो नहीं होते जो इश्तिहारात हम डिस्ट्रीब्यूट कर देते हैं और हम समझते हैं कि जी वो डिस्ट्रीब्यूशन ऑफ इश्तिहारात वर्क इज डन। नो, नाउ दिस टाइम वी विल बी वेरी क्लियर कि किसने क्या कुछ करना है। एक और चीज भी हमने करा दी, मेरे ख्याल में ज्यादा टाइम ले रही हूँ लेकिन मुझे बस 2-4 मिनट और दे दें ताकि मैं आप, हमने एक मीडिया एडवाइजरी फोरम भी बना दिया है। मीडिया एडवाइजरी फोरम में तमाम आपके राइटर, प्रोड्यूसर, नए वन जो पुराने जो थिंक टैंक है, हमारे पास मीडिया का भी ये होता है कि एक मीडिया जो मैं बना रही होती हूँ, बाय द एंड ऑफ द डे पता चलता है कि वो हमारे सोशल कल्चरल उसके साथ चल ही नहीं सकता है, या वो जो हमारा नैरेटिव है वो उसको फुलफिल ही नहीं कर रहा है। एंड वी आर स्पेंडिंग अ लॉट ऑफ मनी ऑन दैट एंड रिसेंटली आई फेस दिस इशू। अब हमारा ये होगा कि ये चीज हम जब CWG में जाएंगे, उस फोरम को भी मैं इनवाइट कर रही हूँ, जो भी बनाए प्रोविंशियल सब्जेक्ट, वी आर नॉट उनको देखो कोई नहीं कर रहे हैं, लेकिन बताएंगे कि जी आपने जो भी चीज बनानी है तो आप ये आपके एक्सपर्ट बैठे हुए हैं, इनसे आप जरा पूछ लीजिएगा, क्या अल्फाज हो, क्या मीडियम हो। इसी तरीके से हमारा उन्मा एडवाइजरी फोरम भी बन गया है, उसकी भी नोटिफिकेशन, क्योंकि विदाउट उन्मा एंड रिलीजियस स्कॉलर और उसमें शिया सुन्नी सब सेट को हमने उसमें ऐड किया हुआ है। यस्टरडे कुछ कल उन्होंने कुछ वो किया था, आगा खान यूनिवर्सिटी वालों ने, उनको कोई एक वर्कशॉप थी मेंस्ट्रुअल साइकिल पर, उसके उस पर के हाइजीन पर था। तो मैं उसमें मैंने उनको ये बताया कि दे वांटेड टू हैव सम सेपरेट गाइडलाइंस और पॉलिसी और समथिंग लाइक दैट, देन आई टोटली डिस्करेज दैट। मैंने उनसे कहा कि जी इस टाइम पे आपकी एक BCC बन रही है, बिहेवियर चेंज कम्युनिकेशन स्ट्रैटेजी नेशनल बन रही है, जिसको पाकपाइंडे को मेरे ख्याल में 4-5 और भी हैं, और वो हम आप लोग उनके साथ बैठे। उसमें एक है आपका पर्सनल हाइजीन का एक चैप्टर है, मेक इट अ पार्ट ऑफ पर्सनल हाइजीन। Why should we make another पूरी strategy for such thing के हम वो, तो हम ये ट्रिक्स एंड बिट्स में अगर काम करना छोड़कर अंडर वन अम्ब्रेला एक डॉक्यूमेंट बना दे, स्टैंडर्डाइजेशन करे, तो मेरा नहीं ख्याल कि हम कहीं पर भी जाएंगे। मेरा ख्याल दिस इज ऑल फ्रॉम माय साइड। थैंक यू सो मच फॉर दिस।
Chalo ji. Thanks very much for enlightening us on the subject. Brigadier Ambreen, would you like to add something?
Very much, Dr. Sabina. I heard you actually recently in our Society of Ops and 9E conference. You were on line. Shahzad Roy was there. And it was so heartening to see, after 35 years of my career, somebody taking family planning seriously. I'm a gynecologist, actually. And the subject has been very close to my heart. I've worked in Malaysia and UK. And I thought always that unless you work on family planning, nothing is going to work. Well, वो ये आपने मीडिया की बात अब कर ही दी है, वो मुझे याद है कि बचपन में हमारे वो सिनेमा में भी जाते थे और टीवी में भी वो बच्चे दो ही अच्छे का ऐड जो आता था। तो मीडिया, आपने खुद अभी एडमिट कर लिया कि कितना इम्पोर्टेंट इन्फ्लुएंसर है हमारी थिंकिंग में। फिर ये कि ओवर नादिया साथ बैठी हैं, मेरे सेम कोलीग्स हैं, और हमारा जो एक्सपीरियंस है, एजुकेशन का मयार बहुत बच्चियों में बढ़ गया है, जनरली शहरी पॉपुलेशन की ज़ाहिर बात हो रही है। लेकिन जहां तक फैमिली प्लानिंग का सवाल है और उसकी थिंकिंग का सवाल है, वो ही है कि यू फर्टिलिटी इज योर कैरियर, और जितनी जल्दी ये कैरियर बनाओगे उतनी जल्दी। और इन्फ्लुएंसर्स जो हैं वो मदर इन लॉ हैं या मदर हैं, और फिर हस्बैंड भी उसके बाद आते हैं। हाँ बिल्कुल, वो भी बाद में ही आता है, क्योंकि उस बेचारे ने तो बोझ उठाना है, अब थोड़ी उनको कुछ सेंस आ है। लेकिन अगर आप रूरल एरियाज में चले जाते हैं तो वहाँ वो उलमा और वो मतलब सिलसिला इस कदर स्ट्रॉन्ग है थिंकिंग। तो वो बात ये है कि जो ग्रास रूट आप CPR इम्प्रूव कैसे करेंगे, आप प्रोविजंस भी दे देंगे, मुफ्त इम्प्लांट्स को तो अब थोड़ा मसला होने लगा, बहरहाल इतना बड़ा वो मसला नहीं है। मुफ्त ये जो टैबलेट्स है प्रोवाइड, घंटों लगाए एजुकेशन पे कि इन टैबलेट्स का कितना फायदा है regarding the menstrual cycle, not you having fibroids, not you having ovarian system stuff. Nothing was because the mindset, the influences, the way I'm working, I am at a loss how to address. I'm not sure if it starts from the school chapters included in the curriculum for children. Maybe that works, or going influencers, picking these lady health workers, picking the influencers because they are local. So they will, they might work. I'm not
sorry,
sure.
मुझसे कुछ चीजें लेकिन this is important कि अब मैं आपको बता दूं. I'm sorry, लेकिन ये कि postpartum में अभी issue आ रहा था local production का. Sorry, contraceptive availability नहीं है. We are working on local production. In the few months हमारे पास एक जो है तो production तो नहीं लेकिन assembling शुरू हो जाएगी. तो लोकली प्रोड्यूस हो जाएगा. इंडिया के साथ हमने किसी न किसी तरीके से, जब तक नहीं है वैसे बेशक दुश्मनी अपनी जगह पर है, वो दुश्मनी नहीं खत्म करेगी, लेकिन फिलहाल हमें IUCT वो ले रहे, लोकल प्रोडक्शन और उसका करा दिया है. पोस्टमार्टम पर मेरे पास यही है कि ये मेरा अनटैप्ड एरिया था. और SOGP के उनको प्रेसिडेंट को मैंने बुलाना है CWG में कि वो हमने इसको वाइडली यूज करना है. GP सब लोगों को वो पोस्टमार्टम प्रेगनेंसी पर ये शुरू करा दी. इन्फ्लुएंसर की आपने मैम जहाँ पर जैसा बात की है दुरेना याब उससे मेरी मुलाकात हुई. वो कह रही थी कि हम लोग यही कहते हैं ना कि उसका खातून वो है ये वाला. उसने मुझे बड़ी अजीब बात बताई और उससे दोबारा आप कभी मौका मिले पूछ लीजिएगा. कहते ज्यादा बच्चे जो है ना सास की ख्वाहिश है ना उसके शौहर की ख्वाहिश है और उसकी इंडिविजुअल ख्वाहिश है. क्योंकि वो कहती है कि मैं ज्यादा बच्चे होंगे, ज्यादा मेरे बच्चे होते मैं ज्यादा स्ट्रॉन्ग होगी. तो ये वाली चीज
जी डॉक्टर नबीला प्लीज.
I'm so sorry, मैं अपनी एज का फायदा उठाते हुए I would like to bring everybody back. हम सबका वो टाइम भी पूरा हो रहा है. Let's come up with 3 or 4 concrete recommendations that this forum can then present to everybody. कि ये moving forward हमें चाहिए. I'm reminded of an email that was circulated by Dr. Kudsia. नई guidelines आ गई हैं postnatal care के ऊपर और ये सारा guidelines are there, everything is there, postpartum पे ये सारा कुछ. All we want is implementation. तो let's join hands और हर लेवल के ऊपर उनकी इम्प्लीमेंटेशन की बात करें. हमारे पास क्वालिटी ऑफ केयर का एक कॉम्पोनेंट है. लेट्स जस्ट डू दैट. अब ये फ्रेमवर्क हम कितनी दफा जब तक हम उनको ट्राई नहीं करेंगे, टेस्ट नहीं करेंगे, हमें नहीं पता चलेगा वो कितने अच्छे नहीं है. लेट्स स्टार्ट इम्प्लीमेंटेशन. फिर उसके बाद आ जाती है मैडम जिस तरह आपने बात की है मैडम इसलिए कि अब आपका वो स्ट्रेचर है ना तो उसमें ये है कि हमारे अगर स्टॉक आउट ऑन द सप्लाई साइड, लेट्स ऑल जॉइन हैंड्स एंड वर्क विद द प्रोविंसेस. लेट्स डू दिस एडवोकेसी के जब तक नहीं होगा तो हमें सप्लाई साइड की चीजें, डिमांड साइड की चीजें एंड कैपेसिटी डेवलपमेंट इन 4-3 पे हम फोकस कर लें. लेट्स स्टार्ट. वो कहते हैं ना कि अपनी शॉप आप अच्छे तरीके से सेट कर लें, पीपल विल कम टू यू. So let's do that. Let's have everybody implement the guidelines. अभी हमारे पास कोविड की गाइडलाइंस इतनी ज्यादा बेशुमार है, कोई काम और करने की जरूरत नहीं. बट लेट्स स्टार्ट एक्टिंग ऑन देम. तो ये चीजें अगर हम अपना लेकर आए एंड देन इफ वी सी कि नहीं अभी और रिसर्च की जरूरत है, अभी और कुछ है, तो दैट कैन हैपन. अदरवाइज फॉरगेट अबाउट विद ड्यू अपॉलजीज. नंबर्स आर इम्पोर्टेंट बट एक भी माँ को नहीं मरना चाहिए, एक भी न्यूबॉर्न को नहीं मरना चाहिए. So let's start implementing. अभी ग्राउंड पे कुछ नहीं है ऑनेस्टली. इस तरह नहीं है. आप रूरल डिस्ट्रिक्ट्स में चले जाएं, वहाँ पे आप हेल्थ फैसिलिटीज में चले जाएं, whatever we are talking here, they are not aware of that. We have to make sure that they know everything. तो हम इसको ट्रिकल डाउन करें नीचे तक और ये हमारी शेयर्ड रिस्पॉन्सिबिलिटी है. हम सबको मिलकर इस पे काम करें.
जी ठीक है. थैंक यू डॉक्टर नबीला, थैंक्स वेरी मच. बिल्कुल जी, गेटिंग द बेसिक्स राइट और स्किल बर्थ अटेंडेंट्स और उसके अलावा कल मैं सुन रहा था TEDx पे टॉक सुन रहा था, उसकी बॉटम लाइन यही थी कि जो बर्थ किट है उसकी कॉस्ट पाकिस्तान में 1500 रुपये है. 1500 रुपीज़ फॉर अ हाइजेनिक बर्थ किट. तो मेरा ख्याल है हम सारे जो बैठे हुए हैं वेल ऑफ हैं. कुछ ना करें ये तो कर सकते हैं कि जहाँ पे हम समझे बर्थ किट्स दे सकते हैं. तो दीज आर द टाइनी सॉल्यूशंस टुवर्ड्स द एंड. अच्छा, इधर मैं थोड़ा छोटा सा एक एक्सपीरियंस शेयर करना चाहूँगा. इन्फ्लुएंस की आपने बात की ना, फिनलैंड में रह रहा था, 20 साल उधर रह के आया हूँ, तो बच्चे मेरे 3 उधर ही पैदा हुए और ऊपर सोमालियन रह रहे थे और उनके कोई 11 बच्चे। तो मेरी बेगम एक दिन उसको एलिवेटर में मिली, वो जो खातून, तो उसने मेरी बेगम से पूछा कि कितने बच्चे हैं, वो कहती है कि 3 बच्चे हैं। कहती मिस्की गेट मोर बेबीज। तो सोमालियंस ये दे मल्टीप्लाई लाइक बनीज, तो इट्स वेरी हमें ये जो इन्फ्लुएंस ग्रुप है इसके मामले में भी वी हैव टू सी।
आप लोगों की एग्जैक्टली आस्क क्या है फ्रॉम द गवर्नमेंट? गाइडलाइंस मैम ये है कि इशू इनका ये है कि पिछले दिनों इन लोगों ने एक वेब पोर्टल वो लॉन्च किया है, WHO ने किया है, एंड आई एम रिसीविंग लेटर्स फ्रॉम प्रेसिडेंट, बार उधर से आ रहे हैं कि हमने उनसे ये कहा कि जी ये जो पोर्टल आपका हुआ है ये अर्ली मैरिज पर रखा, उसको ट्रांसलेशन करके दे दे। अंग्रेजी में तो नहीं, मैंने और आपने तो नहीं समझना ना, आप उसको लोकल लैंग्वेज में करके मुझे दे दे ताकि हम उसको डिसमिनेट वो करा दे। इवन अगर आप लोगों के गाइडलाइंस भी है, अगर आप लोगों के बट वी नीड टू, आई मीन नहीं चलिए वो जस्ट इट वाज जस्ट एन एग्जांपल, बट इफ यू हैव डेवलप्ड ऑल द गाइडलाइंस प्लीज ट्रांसलेट दैट। आप हमें बताएं कि व्हाट एग्जैक्टली यू वांट from the government, from not only from the federal government, even from the provincial government, because we have a platform over there. We can always ask them कि जी ये आप लोग इसमें जाएं, आप हमें बता दें।
We will इंशाल्लाह हमने engage किया हुआ है, we will write a policy document and guidelines.
सर यकीन करें in every meeting I fail to understand कि आप लोगों की exact कि आप अपनी आस्क बताएं, and we will tell you कि हाँ जी we can do.
We will get back to you इंशाल्लाह। ये प्रोफेसर नबिया है हमारे साथ अल शिफा से, she would like to say something.
मैंने बता दिया, हमने यहाँ के लिए कॉन्ट्रसेप्टिव का जो है तो हमने ऑडियो प्लेस कर लिया फॉर ICT GB and AJK इन दिस मंथ, आपको वो मिल जाएंगे, उनके साथ उनकी हम पोजीशन आपको हम बता देंगे। जेडाइल इज नॉट अवेलेबल, उसके लिए आई एम ट्राइंग माय बेस्ट, जर्मनी तक मैं लेके तो आप मुझे आज करनी भी बता दीजिएगा, वी आर हियर टू हेल्प यू आउट। क्या मैं आपको एक मैं बार उसमें वो करा तो मुझे किसी बाहर से अमेरिका से, मैं आई एम नॉट गोइंग टू नेम दैट ऑर्गेनाइजेशन, किसी अमेरिका से मुझे ये आया कि जी वी वांट टू कंडक्ट अ स्टडी, 6000 खवातीन की हमने उनसे पूछना है सवाल क्या है, हम उनको 6 के साथ ऑप्शन ऑफ कॉन्ट्रसेप्टिव देंगे, उनसे पूछेंगे कि उनका प्रेफर्ड मेथड कौन सा है, कौन सा कॉन्ट्रसेप्टिव, तो वो हमने वो पुश्तों में कहते हैं जिसको पठान।
I'm sorry, we would like to go to the conclusion because we have a class here at 4 o'clock.
बस जी एक ये तो उनसे मैंने ये कहा कि जी हम लोग we are fighting for the main simple bread and you are asking for cakes and pastries. आप हमें 6 किस्म के अवेलेबल करा दे, then we will go for the research आप हमसे बात तो आप हमें बता दें whatever you want.
We will inshallah. जी Dr. Nabiya.
Thank you so much for very enlightening discussion on reducing maternal mortality. We are here to reduce maternal mortality. The first thing which is the most important is to reduce the CPR. ये जो आपका data show करता है modern contraception, उसमें से if you figure it out, तो modern contraception है ही नहीं, उसमें इतना 25% वो भी ever used में आ जाता है। तो basic the first thing what the ulama has done in our society, सबसे ज्यादा रिलीजन पार्ट खेला जाता है फॉर कॉन्ट्रासेप्शन। कॉन्ट्रासेप्शन अवेलेबिलिटी की जब आप पेशेंट के साथ बात करते हैं, PPIUCD की बात करते हैं, रिलीजन सबसे पहले उनको आगे पीछे मुसलमान होना याद आए ना आए, उस टाइम पे जब हम कहते हैं PPIUCD रखवा दो, इवन इन शिफा इंटरनेशनल हॉस्पिटल जो कि प्राइवेट ऑर्गेनाइजेशन है, आई एम प्रोवाइडिंग PPIUCD फ्री ऑफ कॉस्ट। उनको मैं स्पेशल इंसेंटिव देती हूँ कि दिस आई हैव दिस विद मी, I will place you whether in cesarean or normal delivery. I have provided to all the residents as well कि ये आपने फ्री रख देनी है, और we start counseling from the pregnancy. कोई फायदा नहीं। हाँ, तो बेसिकली हमारा मीडिया प्रोजेक्ट करना, उलमा को बीच में डालना, कन्विंस पीपल कि दिस इज द फर्स्ट इम्पोर्टेंस। इफ यू रिड्यूस CPR, आपके प्रेग्नेंट नहीं होंगी, इंड्यूस्ड अबॉर्शंस नहीं होंगे, आपका मल्टी पैरिटी की वजह से एनीमिया नहीं होगा, मल्टी पैरिटी की वजह से आपका हेमरेज नहीं होगा, पोस्टमार्टम हेमरेज से आप बचेंगे। तो ये सारी चीजें लिंक्ड हैं to prevention rather than cure.
जी, thanks very much. Dr. Aisha, would you like to say something?
बहुत कुछ कह दिया है। मैं सिर्फ ये डॉक्टर सबीना एक दो चीजें बताऊंगी। एक तो ये कि जो सारे कुछ हम कर रहे हैं और जो इम्प्लीमेंटेशन कर रहे हैं उसमें मॉनिटरिंग की बहुत ज्यादा जरूरत है, क्योंकि पिछले 30 साल से मैं भी नबीला के साथ की, समझ लें मुझे 2-1 साल आगे पीछे, हम जो काम कर रहे हैं हम देखते हैं जो भी काम हो रहा होता है वो इम्प्लीमेंट नहीं हो रहा होता। पहले निफ्स जो था पॉपुलेशन वेलफेयर प्रोग्राम के कंपोनेंट्स एवेलुएट करता था, अब हेल्थ के कंपोनेंट्स भी एवेलुएट कर रहे हैं। और हम ये देख रहे हैं कि जैसे इवन लड़कियां, मेरी सर्वे वाली बताती हैं कि पोलियो के खतरे हमने खुद देखा है कि बच्चे के मुंह में जाने के बजाय बाहर चले गए तो उस बच्चे को तो पोलियो होगा ही। और इसी तरह जो चीजें आपकी, जैसे अभी आप कह रही थी कि सीपीआर और वो जो डिफरेंस आ रहा है वो एफडब्ल्यूसी से जो और RH सेंटर से डेटा पीबीएस को आ रहा है, वो उनका कसूर नहीं है। पीबीएस का जो डेटा वहां से नीचे से भेज रहे हैं वो डेटा गलत भेज रहे हैं। और जो पीएमए की स्टडी हमारी जो मॉनिटरिंग एवेल्युएशन की हमने अभी की है उसमें यही हमने बताया कि हमने वहां जाकर उनसे डेटा कलेक्ट किया और उसमें इतना डिफरेंस है कि हम खुद भी बड़े परेशान हो गए। तो बेसिक चीज ये है कि ये सारी चीजें जो हैं हम जब तक उनको प्रॉपरली नहीं कर रहे, इम्प्लीमेंटेशन भी, पैसे भी लगा रहे हैं, वो हो ही नहीं रही वहाँ ग्रास रूट लेवल पे, तो उस पर कोई इफेक्ट नहीं होगा। और दूसरा एक क्वेश्चन था, जब मैं पढ़ने गई थी इंग्लैंड तो मेरे टीचर ने पूछा था कि बांग्लादेश आपका हिस्सा है तो आप पाकिस्तान और उसमें इतना फर्क क्यों है। और अब तक यही क्वेश्चन चल रहा है, जैसे सर ने ये कहा है कि वहाँ का मैटरनल मोर्टेलिटी रेट में बहुत ज़्यादा डिफरेंस है, पाकिस्तान में क्यों नहीं है। आप इस सवाल का जवाब हमें कहीं से ले दें, पढ़े लिखे लोगों से, जाहिलों से। तो क्योंकि आपसे मैंने CPR भी क्यों ज़्यादा है, मेरे टीचर ने कहा कि CPR क्यों ज़्यादा है वहाँ से, क्योंकि कि मतलब हाँ उस वक्त उन्होंने लेकिन मेरा तो ख्याल है कि पॉलिटिकल कमिटमेंट और सीनियर लेवल की कमिटमेंट थी जो वहाँ बांग्लादेश में और यहाँ पर नहीं है उस हिसाब से। थैंक यू।
चलें, thanks very much जी. I would like to conclude the day. We are very thankful to WHO and NIPS specifically कि इनके साथ मिलके we could have this maternal mortality survey workshop. I'm really thankful to Professor Dr. Midhat. जब से ये आए हैं ये यानी हमारे साथ इन्होंने we had this in our mind कि we should have this workshop on one of the greatest surveys ever. और अभी यहाँ पे ये कहानी ख़त्म नहीं हुई, इंशाल्लाह यहाँ से इस workshop से all these presenters, all these researchers will join together and will write few publications out of it. 8-10 papers इस पे हम लिखेंगे। इसके अलावा गवर्नमेंट को इंशाल्लाह concrete guidelines और policy matters जाएंगे जिस पे वो आगे चल सकेंगे। डॉक्टर साहब आप कुछ कहना चाहेंगे in the end or shall I just conclude? आप कुछ कहना चाहेंगे मिदत साहब?
मैं दो बातें कहना चाहूँगा। एक तो ये कि जो मतलब I'll be very very frank, I have to say the truth. हमारे यहाँ political rhetoric है, commitment नहीं। बांग्लादेश में political rhetoric नहीं थी, commitment थी। That's the biggest difference I think. 3 साल हो गए जो हमें procurement अभी चल रही है। I mean, I've been part of this whole system. It's not happening yet. So if it's happening now, that's a very good news. ये तो चलें कंट्रासेप्शन की बात हो गई। ये तो मतलब हमारा आज का टॉपिक जो था मैटरनल मोर्टालिटी था, उसमें मेरा ख्याल है कि जो हमने अभी तक जो मतलब बेसिकली जो बात की है वो ये कि हमें 4-5 चीज़ें जो पता चली इस सर्वे से, कम से कम उस पर ही जो है हम शुरू करें। तो उसके लिए एक समरी प्रेजेंटेशन थी मैडम, आपने मिस की क्योंकि वो विल सेंड इट टू यू। उसमें बेसिकली जो ना कोई 6 या 7 ऐसे पॉइंट हैं जो इजीली मतलब गवर्नमेंट कैन स्टार्ट कंसीडरिंग। And that is something, we talked about ASHA, we talked about cesarean sections, we talked about health service utilization and how the quality is affecting that. And that actually is a summary which is entirely based on evidence, the evidence which is coming from the lab. Inshallah, I will share it with you and thank you.
चलें जी, थैंक्स वेरी मच। और इलामा इकबाल ने मैटरनल मोर्टेलिटी पे कुछ 100 साल पहले एक शेर कहा था, उस पर मेरा ख्याल इख्तिताम करते हैं। वजूद जन से है तस्वीर कायनात में रंग, इसी के साथ से है जिंदगी का सोज़ दरूं। थैंक यू।
इसके तशरीह के लिए अल्लामा इकबाल से लाजमी है पूछिएगा कि उनका मतलब क्या था। वो किस